I'd like to invite the chairpersons onto the dais, please. Dr. P.G. Mohandas and Dr. Madhu Murali, please. We expect Dr. Sri Kumar to join us shortly. The first speaker of this session, Dr. K.V. Gangadharan, medical oncologist, Aston MIMS, Calicut. Over to our chairpersons now. Delegates standing in the back, I request to take your seats, please. Thank you. May I request Dr. Gangadharan to kindly deliver his lecture. Over to our chairpersons, please.
So thanks to organizers of PGCME program organized by Kerala chapter of Surgical Association. Topic we are here chosen is totally different, and is targeted therapy. We are hearing about the different surgical procedures and details. They are totally different topics. I am very happy today here because I am part of MES Medical College for almost 12 years, from 2005 to 16. I'm basically coming for 2 days every week. So we have initiated the medical oncology department here. So this topic is, target therapy is basically a personalized medicine or precision medicine. Each malignancy is considered as a heterogeneous, totally heterogeneous group of disorder. So by evolving the various research programs, molecular biology programs, the specific molecular targets for each malignancy, specific molecules, by looking at the DNA gene sequencing or specific protein, we can target the specific molecules to cell killing. So concept is that right patient, right targets, right drugs, right time, producing increased efficacy and better outcome. So they basically focus on identifying and specifically targeting the unique molecule or genetic characteristics of cancer cell by looking at the gene sequencing. So oncology is always evolving from starting initially with surgical treatment only options, then later on radiotherapy principles, then chemotherapy. From 2000 onwards, there's no new chemotherapy drugs. Always initiated by monoclonal antibodies, tyrosine kinase inhibitors, then combination of drug conjugates. So no new chemotherapy drugs from 2000 onwards. Everything comes as targeted drugs, target molecules. If you look for the major malignancies, breast cancer, one of the important drugs is trastuzumab, lymphoma, rituximab. Lung cancer, there are tremendous improvements by looking at this EGFR mutation, ALK mutation, RAS mutation. There are specific targets. They are responding where we know we don't want to use chemotherapy drugs. So these drugs are totally different. They are by looking at these molecular targets, especially if simple example is CML, BCR-ABL tyrosine kinase inhibitors. Imatinib has totally changed the treatment of chronic myeloid leukemia. As for other thing is, we have a GIST, metastatic GIST, c-KIT receptor. Again, imatinib has totally changed the treatment of options. We just look at advanced renal cell carcinoma. There's no chemotherapy drugs. Usually, what we think of purely give supportive care or a palliative RT. Now there are multiple tyrosine kinase inhibitors acting on various sites. VEGF receptors, PDGF receptors, KIT antigen, or there are new immunotherapy molecules for renal cell carcinoma. Now the metastatic RCC almost 40% surviving for more than 5 years. Other thing is we look for the melanoma. Melanoma, there is again chemotherapy data percent response rate 8%, very poor outcome. But if you look now the totally advanced melanoma means look for the molecular markers, BRAF mutations, PD-L1 status, then plan our treatment. If there is a BRAF mutation where we have the targeting drugs are available, 30% of the patients are surviving more than 5 years. Advanced melanoma, immunotherapy combinations producing 10 years survival rate. So these molecules change the overall treatment outcome in advanced malignancies. So mainly thing is looking for the molecular targets, development of target drugs. Then it's a patient specific. Always it's individualized treatment plan. There is no homogeneous plan. Always look for each patient, each like pathology, molecular biology, assess the genomic sequencing, then planning treatment. So for PG's discussion, we have mainly the three different types: monoclonal antibodies, small molecular inhibitors, tyrosine kinase inhibitors. This everything is acting on cellular signaling pathways. Angiogenesis inhibitors, hormone therapies, especially in breast and prostate cancer, PARP inhibitors. PARP inhibitors are mainly effective in BRCA mutated tumors, BRCA mutated breast and ovarian cancers. Other thing is last 2006 onwards, 2010 onwards, there's an emergence of immunotherapy. There is a major, almost if you look for any advanced malignancies, look for there are various molecules acting on PD-1, PD-L1 receptors to enhance the immune system for cell killing. These are simple example. Look for specific targets. Specific target, there are multiple targets, but look for specific target mutation for that disease. Drugs acting on specific targets, we can control the disease. Majority of target therapies control the disease, stabilize the disease, partial response or minimal response. Very few complete response rates, but they prolong for long period, 5 years, 6 years, 7 years. So symptomatic control is there, good quality of life. Few patients are long-term cure rate. Especially if you think of immunotherapy, response is in 10 to 15% of patients, but 10% of patients are surviving for 10 years, 5 years, long response rates. It's a basic picture showing acting on receptors. You're going to look initially acting on ligands, then receptors, then followed by multiple signaling pathways inside the cells. Again, it's a very vast area. We have got ER receptors in breast cancer, EGFR in breast, lung, colorectal cancers, HER2 again breast cancer, GI malignancy, D-junction malignancies, VEGF receptors in multiple malignancies, colorectal cancers, renal cell carcinomas, VEGF receptors again in hepatomas, mTOR inhibitors again in breast cancer, RCC, CDK4 inhibitors. That is a new drug, CDK4/6 inhibitors, especially in ERPR positive, HER2 negative metastatic breast cancer. Now these drugs are coming as a locally advanced, as adjuvant treatment in locally advanced breast cancer. c-KIT receptors in again GIST, imatinib is a very important drugs. BRAF inhibitors again in melanomas, CTLA4 in melanomas, androgen receptors in again prostate cancers. This is one of the drugs. Vemurafenib is especially useful in mutated BRAF mutated melanomas, producing a very good response rate after 3 months. Again, HERA trial showing a significant OS and DFS benefit in adjuvant breast cancer. Now they have multiple targets. You initially think of unit-targeted. Now multiple targeted kinase inhibitors. They are acting on VEGF receptors, PDGF receptors, RET, KIT, so that outcome is more response rates with less toxicity. They have different toxicity profile, so we can target the multiple targets, producing outcome. Especially these drugs are more useful in renal cell carcinomas and hepatomas. Multi-targeted kinase inhibitors, sorafenib, lenvatinib. There are multi-targeted kinase inhibitors. These are multi-targeted kinase inhibitors in renal cell carcinoma. If you look for the response in locally, nodal diseases are responding, as well as metastatic focus are responding. 3 sites are responding after 3 months of treatment with the sunitinib. Toxicity profile are totally different. You think of main toxicity is skin, soft tissue toxicity are more. Other thing is hypokalemia, hypomagnesemia, QT prolongations, proteinuria, hypothyroidism, hypertension. These are the toxicities. While looking this clinical patient on TK, they always think of these kind of toxicities: hypomagnesemia, hypokalemia, hypothyroidism, skin and soft tissue toxicities. So these are different profile of toxicities compared to chemo drugs. These are the recent emergence of immunotherapy drugs. Basically, they are checkpoint inhibitors. Checkpoint inhibitors are our immune system is very strong defense against cancer. But there are few checkpoints. They are controlling the immune system. They are manipulating this checkpoint. We can boost our T cell, T lymphocyte to produce immune burst, then followed by killing of cells, producing memory cell, then naturally long-lasting effects. 10% of malignancy, especially advanced lung cancer, advanced bladder cancers, advanced colorectal cancers, advanced melanomas, where 10 to 20% of patients are doing very well. Especially, I think 10% are doing a long period of good outcome, good response rate. This is one study showing a 30% of patients on melanoma with a combination of nivolumab plus ipilimumab doing long survivors after 10 years. But again, here the response are totally different. Don't look for size alone. Look for necrosis tumor. Size may be increasing, but you look for necrosis tumors, then assess the symptoms of patients. Once you put on CT scan, size may be more, but tumor is necrosed very well. This is again all positive in advanced lung cancer. EGFR mutation tumors are responding very well with anti-EGFR therapy. ALK rearrangement tumors are responded to anti-ALK agents in lung cancer. ROS rearrangement, again lung cancer, responded well. This is again important slide for PGs. I'm talking this slide is breast cancer is a totally different molecular subtype. They are divided into luminal A, luminal B, normal like, HER2 positive, basal like. By looking at the ER, PR, HER2 nuance, these three important markers are ER, PR, HER2 nuance, KS7, divided into 5 different subtypes. HER2 is a very important target for a breast cancer. There are various molecules targeting HER2. It is important neoadjuvant, adjuvant, as well as metastatic disease. In improving the DFS, OS, oral survival, multiple drugs are available to target HER2 positive breast cancer. These are important new molecules coming in oncology practice. CD, cyclin-dependent kinase 4 and 6 inhibitors. These are important drugs for PR positive, HER2 negative disease, advanced disease. As well as now it is coming in locally advanced disease as adjuvant treatment. EGFR inhibitors are especially cetuximab and panitumumab are important drugs for advanced colorectal cancer, especially RAS wild type disease. Again, I'm not going for details. It's basically acting on cell cycle and different sites of cell cycle. To conclude, it's a major advance in treatment of improving the outcomes. Always think of NGS studies, gene sequencing in any advanced malignancy. Think of a molecular tumor board in all hospitals or major hospitals, because now it's emerging as a molecular tumor board is emerging, especially with the discussion with pathologists and molecular scientists. Thank you for patient hearing.
Very good talk, Gangadharan. See, I think because the cure rates of lot of malignancies are improving because of the advances like targeted therapy and advances in radiation. I think surgery has almost reached a plateau. We are trying new methods and things like that to do. But then it's very great. But could benefit to the audience, could you just tell what will be the cost of an NGS panel or something like that? Where
these are the new drugs, new molecules. See, everything is evolving. Oncology is each and every day is evolving. Cost is also evolving. So if you consider the NGS study of an Indian data, if you want to look for all genomes, almost cost is 1.4 lakhs. For if you want to send to outside, this cost is 3.2 lakhs. But if you look for specific mutations, EGFR, ALK, ROS, PD-L1 in lung cancer, cost is 8,000 only. If you want to look for BCR-ABL in CML, it costs 3,000 rupees only. So don't think everything is too costly. We want to look for specific mutation, cost is less. Outcome is very, very good, because now the gefitinib cost is only 3,000 per month. Initially in multinational single drug cost is 75,000, now it is 3,000 only. So cost is coming down. There are various ways to plan the treatment, various ways to discuss the issues.
Right, as you rightly said, sir, previously as a surgeon, I used to be a bit skeptical about these drugs. Two reasons. One is the cost factor. And as you rightly said, over the last 5 years or so, what you can see is that most of the target agents are coming down on the drugs. So the drugs which used to
Indian brands are coming.
Indian brands are coming. So all this immunotherapy, I believe in another 5 years or 10 years will come down to less than 10,000 a month.
Yes, correct.
Which are 1.5. You can take from the history of Herceptin, which used to be.
Yes. Now it is 7,000 rupees.
7,000 rupees per vial. So it is affordable. Second point is that as surgeons, we need to understand is that all these drugs used to be in the metastatic setting, but we have significant number of these drugs coming into adjuvant setting, especially
and new adjuvant setting.
Neoadjuvant, lung, esophagus, and breast. So we should also be aware of the indications and what are the utilities of these drugs. Sijin.
Dr. Gangadharan, I have a question, and maybe a foolish one, but are these markers and biological markers, everything, correlated with the tumor biology?
Yes, very correct.
Because we find that the same well differential carcinoma operated in different patients behave differently, even after an R0 resection. So, what are the newer modalities for assessing the biological or predicting the biological behavior of tumors? And what is the result regarding this new maps and all, whether it correlates with the activity?
Very good question, because we have got various molecular targets, various biologicals to look for prognosis also. Example is, simple answer is HER2 overexpression seen in 15-30% of breast cancer. There are usually ERPR negative, they are high-grade tumors. Usually outcome is compared to ERPR positive patient are less. We have got a very good molecule called anti-HER2 agents are there. Once you put on anti-HER2 agents, that part is covered by anti-HER2 agents. ERPR negative, other part is covered by chemotherapy. So it's a totally cancerous heterogeneous. Each individual cancer is again molecular biology is different. So other thing is prostate cancer. We have got androgen receptor blockers are there. So if you look for the ERPR status, ERPR HER2 advanced disease, we have got a CDK4 inhibitors. They are very potentially active drugs, putting a very good overall survival rate. So these are again CD20 molecular antibodies, rituximab, established drug for treatment of lymphomas. So there are many molecules which are evolved on the period of gradually evolved over a period of 10 to 20 years. It have got specific actions, specific cell killing by targeting these drugs. Simple. Other thing I again explain that advanced lung cancer always. If you are non-small cell cancer, adenocarcinoma, think of EGFR, ALK, ROS, PD-L1 status. If it's EGFR positive, specific mutations, response rate is 70%. They are doing for 3 years, 4 years without any complications. There are few patients are surviving more than 10 years. That's putting a single small drugs, oral drugs. They are a reality. Now is a target drug is a reality. Very good response, but you have to assess the patient details. What is the way and different? For example, in lung cancer, there is different biology. Non-small cell lung cancer, one is smoking related, other is non-smoking related. Female, women, adenocarcinoma, non-smokers are totally different biology. Where we get a EGFR mutation positivity. ALK receptors are other important receptors. They are present in 4% of advanced lung cancer. Response is 80% response, including brain secondaries. So patients with advanced lung cancer brain secondaries are surviving more than 5 years. Melanoma, it because of BRAF mutations. Once you find out BRAF mutations, anti-BRAF agents produce a very good outcome. So there are many drugs, many malignancy we have various molecules, but it's costly. Many drugs are costly, especially immunotherapy cost is really costly, 2 lakhs rupees per cycle. Outcome only 10%. If someone have advanced hepatoma, we have one of the drugs is immunotherapy plus Avastin, where the long-term outcomes only seen in 10% of patients. Cost is 3 lakhs per cycle. So there we want to discuss each and everything once in details to patients, then to finally decide the treatment options.
Thank you. Thank you.
Dr. Gangaran, thank you for the wonderful talk.
Thank you,
Sir, in melanoma, one last question, please. In melanoma, can we have, I come from basically government medical college setting. So what are the drugs that we can use comfortably in a low resource setting in melanoma?
No drugs. Everything all costly.
Thank you.
Thank you, sir.
We'll go to the next talk.
Dr. Gangadharan, may I please request you to kindly stay back on the dais? Sorry, sir. Beg your pardon. I request the chairpersons to kindly do the honors and present Dr. Gangadharan with the certificate. Thank you, sir. Our next speaker in the Master Lectures class is Dr. Satishan Balasubramaniam, surgical oncologist from Talasheri.
Good afternoon. Thanks, ASI, Dr. Murli, Dr. Siddiq. Now, I just want to alert the surgeons. Dr. Gangadharan has just informed us in another 20-30 years of time, surgical oncologists will be doing only biopsy. I think most of the tumors, I think we'll be treating with medicines. Now already a few wonder drugs have come, and there has been rectal cancers. it has found that almost 100% results. So with no surgery. So this is something, the evolution of medical oncology, especially immunotherapy, is very drastic, and that is going to stay for. So my topic here is that a comprehensive approach to soft tissue sarcomas. So the background is that soft tissue sarcoma is a rare tumor. If you take maybe 100 tumors, 100 soft tissue tumors, only 1% is soft tissue sarcoma. If you take all cancers together, there's only 1% comes in soft tissue sarcoma in adult. In pediatrics, around 15%. In pediatric soft tissue sarcomas, biologically, they are different from adult soft tissue sarcomas. And very important thing, it's a very heterogeneous group. We have got multiple histologies, and over the period, again and again, newer histologies and newer subclassifications are coming up. And the most common site is extremity, and followed by trunk and viscera and retroperitoneum. One of the problems with soft tissue sarcoma is that it's a disease of maybe adolescent and also young adult and in the middle age. So because that occurs during the period of our reproductive age group, and also they are the most productive period of our life. And it is often misdiagnosed because the benign tumors actually overwhelmingly large when compared to soft tissue sarcomas. So naturally, there is a high possibility of misdiagnosis and under-evaluation. And so many patients do present with, they are being mistaken as benign tumors and they undergo surgery. So major problem is the morbidity. And a very important aspect in oncology is that, it's a multidisciplinary approach. And the soft tissue sarcoma is no way different. Our management is always multidisciplinary. And this is mainly for the postgraduates, attention. You have to remember this as 5 hereditary syndromes. One is this Leigh-Fromedy syndrome. Leigh-Fromedy is a P53 mutation, and this is otherwise called SBLA syndrome. Sarcoma, leukemia, and brain tumors, and all these things, it comes in the Leigh-Fromedy syndrome. And undifferentiated glioma of sarcoma, RMS, and these are the common tumors. Then FAP, especially Gardner syndrome, where you got aggressive fibromatosis, then Carney-Strattakis syndrome, then hereditary retinoblastoma syndrome, and neurofibromatosis. All these 5 hereditary syndromes are also soft tissue sarcomas. So when to consider this software, because often we are very good in treating primary tumors and all this, but many often we miss out when we have to do some hereditary search, because this is something which we lag behind in our country. And there are certain groups which we have to strongly think probably whether we should consider hereditary testing. One is those patients with personal history of, any size in the family history of Leigh-Fromedy syndrome, those people with the GIST, which is lacking the c-KIT mutation or PDGFR mutations, those patients with desmoid tumors, fibromatosis. Then we have to think probably whether it is going to underlying FAP or Gardner syndrome. So this is our data from institute, and this is why I put up the slide not to show the statistics, just to bring it an idea to the postgraduates. The registries. There are 2 registries generally called hospital-based cancer registry, and hospital-based registry. All those patients who are coming to hospital, we take their demographic details and look at the pathology, how they are treated, and all those things. And this has to be there in every center which is treating cancer, because you will get the data on what are the cancers being treated. So if you look at it, it's only around 1% is the incidence of cancer in the registry. This is a hospital base, what we have treated in MCC. And this is, this is this is PBCR, population-based cancer registry data. And it shows that, it is only the age-adjusted rate. Age-adjusted rate means if you take, across the world and we take age to a certain standard, and then we calculate the incidence. So age-adjusted status is very low. It is only 1.25. That means all those cancers which incidence is less than 6 per 1 lakh population are generally considered as a rare cancers. So soft tissue sarcoma is also a rare cancer. The principles of management, important thing is a proper evaluation, clinical examination, and investigation should be appropriate. And we have to have a tissue diagnosis. That is very, very important. And we have to prepare the patient for treatment. That is a very, very important aspect of it, because most of the sarcomas happen in the extremities. So the locomotion is a very important aspect, and many people who have been working, if the sarcoma happens in the high, sometimes they may not be able to work with the hand. So all these things which you have to consider. So we have to prepare the patient for that. And multidisciplinary approach, the teamwork is very, very important. Surgeon is a leader in the team. He's a lead member. I don't care if he's a leader. And very important, similarly, all the important, rehabilitation experts, pathologists, radiation oncologists, all these are important team members. And some cases we have to, because this team has to decide whether this patient needs a neoadjuvant treatment before surgery, whether we should give any other treatment. And we should have a clear-cut follow-up strategy. So the important thing for the postgraduates, how we look upon a patient with soft tissue sarcoma, because we look upon certain histologies. For example, if the pathology report says small cell sarcoma, be alert, because small cell tumors are some tumors and which respond well to chemotherapy. So small cell tumors could be a lymphoma, it could be a PNET, or it could be a small cell liposarcoma. So small cell round cell tumors, and we have to be careful. Another one is there are some histologies that are lymph node metastasis. So we'll have to specifically look at the lymph node basin, whether there's any nodal metastasis. For example, epithelioid sarcoma, clear cell sarcoma. Clear cell sarcoma is nothing but it is a malignant melanoma of the top part. Then rhabdomyosarcoma, angiosarcoma. So these are some of the tumors which we have to look at. So whenever we get a pathology, we have to look into what histology is there. So this histology will guide us what we have to do next. And this is a very important part, natural history, because natural history is something which we need to know to plan treatment of a cancer. It actually, in soft tissue sarcoma, when it originates in the muscle, it expands in a centripetal fashion. That means expands outside. When it expands outside, it compresses the normal tissue all around. So what happens? This compressed tissue becomes form a pseudocapsule. So once it is pseudocapsule, the body will react, because any tumor, any cancer in the body is a foreign body to the body. So the immune system will work against it. So what the immune system, it will bring in infiltrates, it will produce the lymphocytes and also neutrophils. Everybody will come there and they'll start attacking, will form an edema around that. That part is called reactive zone. So once the reactive zone is formed, why this is important? Because as the tumor grows, generally as a principle, any tumor growing more than 5 mm, so naturally they have to get a blood supply from nearby area. Till then, and it can have, based on diffusion, it can work. So what happens when the tumor is growing? Naturally, it has to invite blood vessels from, so neoangiogenesis. So blood vessels from various parts will go through the pseudocapsule into the tumor to supply that. So this area will become a weaker area. So the tumor is growing. When the tumor is growing, so it will find weaker area through which the tumor buds in. So that through the small holes through which the vessel comes, the tumor grows outside. So that forms the pseudopods. These pseudopods will get disconnected and they'll stay in the reactive zone. So when they stay in the reactive zone, and this is when we find the soft tissue sarcoma, we can very easily enucleate. We can just put a finger around, the entire tumor will pop up because there is edema around the tumor. So that is the reactive zone. When you pop out, its resection is something very easy. It is because you preserve all the structure. Problem is that we are spilling the tumor over there because all these pseudopods and small nodules are still there. Some tumor cells will get into the blood vessel and they travel a long distance in the same compartment and they stay there and they, this is called satellite metastasis. So skip metastasis. And generally soft tissue, so this is the natural list of soft tissue sarcoma, then they spread to lungs, bones, liver. Lung is the most common site of metastasis. So the evaluation again, because once we know the natural history, so our evaluation plan is based on that. So after the detailed history and this one, X-ray chest, NOPI, take an X-ray chest. X-ray chest, it shows metastasis, a large tumor, more than 5-6 centimeter tumor is there. I think you have to think maybe a soft tissue sarcoma. For example, an X-ray chest shows a large tumor there, and there is another tumor in the soft tissue. Could be a primary with a metastasis in the soft tissue. Local imaging is very, very important before putting a needle, before putting an FNAC or biopsy. Always do a local imaging. Do an MRI or a CT scan. MRI is its preferred modality. We do an MRI and find out on what type of tumor it is and where the location of tumor. It's a deep-seated or superficial tumor. Then comes the biopsy. Biopsy is a very important aspect. Come to the biopsy. Then CT of the chest. So all these things I don't put a chronological order to bring out how we evaluate. So CT chest, because around 10-20% of cases, X-ray chest miss out a metastasis. PET scan is not the primary investigation for soft tissue sarcoma. We use only in selected cases, especially recurrent tumors. So bone scan, only in 2 situations we use. One, the tumor is adherent to the bone. Yes, if want to. That depends on, again, on people or suspecting infiltration. Another important aspect is that if the patient's LFT shows elevated alkaline phosphatase, this is common for all tumors too. Any patient with elevated serum alkaline phosphatase, bone scan is a indication. So there are certain, again, histology why is important? Some of the histologies behave differently. For example, we have to do an abdominal pelvis and abdominal and pelvic CT in the case of angiosarcoma because they got a metastasis to liver is common, epithelioid sarcoma and myxoid round cell sarcomas. CNS metastasis again in common in case of angiosarcoma, alveolar soft part sarcomas and cardiac sarcomas is up. So this becomes the part of evaluation. Then spine and whole MRI, again myxoid round cell tumors. Biopsy technique, FNAC is not generally not recommended. It's a recurrent soft tissue sarcomas, presence of history of a tumor elsewhere, and metastatic disease. If only we are planning for best supportive care, we do that. Core needle biopsy, we have to take good number of biopsies. Open biopsy, only in selected cases, only in the line of the future incision, you have to put that, preferably in a center which treats soft tissue sarcomas regularly. Ancillary testing, this is very important, apart from the immunohistochemistry, PCR, FISH, etc., for the molecular analysis, because the management, not just histology now, because no pathologist nowadays gives only histological diagnosis. They always do ISC, sometimes they go for FISH to diagnose soft tissue sarcoma. Then this is a staging, which I think I just wanted to bring it to notice. Now, surgical principle, I just wanted to put the main surgical principle is a wide local excision. Wide local excision means there should be normal tissue all around the tumor, at least 1 centimeter margin. Less than 1 centimeter margin, it is called closed margin. So if you get 1 centimeter margin on table, you have to give at least 3 centimeters, because there will be around 30% shrinkage of the tumor after surgery. So when you do that, when a tumor is superficially located or its skin is stretched out, an elliptical incision, and dissect the tumor, dissect the flaps beyond the tumor for at least 3 or 4 centimeters and start resecting it. And frozen section is important for margins. Vessels and nerves, you can take perineurium or adventitia as a margin and you can take it, or it could be a periosteum, could be a margin. After surgery, always put clips, because this is very important for you to inform the pathologist on what is the tumor node. What's the site of radiotherapy. Indications, it should be, this is something which, right. Now, the limb salvage. Limb salvage is very important because it depends on the type of the tumor, large tumors, whether we put a neoadjuvant treatment and all those things. Preservation of limb is the strategy, and we try to preserve the limb as much as possible. But important thing is that whatever the limb you preserve should be useful to the patient. If it is functionally useless, don't do limb salvage surgery, because it's not a good thing. You can always do an amputation and put the process. Nowadays, the processes are very good and the quality of life is not much different. Barriers, limb salvage, main barrier is that poorly placed incisions. If you put an incision transversely in a thigh, naturally when we go for surgery, re-resections will be very difficult, because large area of skin has to be lost, then we have to do reconstruction, the problem. Similarly, vascular encasement is very important. If vascular encasement is there, always plan for resection of the vessels. Again, soft tissue sarcoma surgery, entire plan has to be done preoperatively, because you should be able to face everything. If there's a nerve is involved, what level you'll say, okay, this is unresectable. So if the sciatic nerve is involved, you can resect it. Femoral nerve is involved, yes, you can resect. But femoral nerve and sciatic nerve, you have to resect it, don't do it. Similarly, and any presence of infection is again a contraindication. Ultimately, our aim is that's a functionally useful limb. So this is something, this is some on soft tissue sarcoma, synovial sarcoma of the ankle, which we had to resect it, and because it had to resect the part of the bone also, we fixed the ankle was resected and the reconstruction was done. For lymphadenectomy, sarcoma in the nodal basin, axilla or in the inguinal region, yes, the nodes will also come along with that. And specific histologies, you look for that. And prophylactic nodal dissection, controversial. In clear cell sarcoma, people do consider. And pathologist is a very, very important part of it. So you have to keep a pathologist in good mood, because pathologist is a person who is going to decide whether you're a good surgeon or bad surgeon. Because the pathologist, if it is margins is not properly clearly given, or if it is not reported, the report is incomplete. The problem is that if the patient goes to another place, and they will always advise re-resection. So pathologist, they should have a minimum standards are there by which way they have to report. They should be there. The margin should be clearly mentioned. And OOPS procedure, this is one thing which we have to know. Without any proper evaluation or without suspecting cancer, sometimes we do surgery and we remove the soft tissue tumor. This procedure is called OOPS procedure, because after that the pathology comes and it comes as a sarcoma, then we have to go for re-resection. And according to our data, nearly 45% of patients whom we have done re-resection had residual tumor. Neoadjuvant treatment, in certain conditions we use neoadjuvant treatment, that is a large tumors, and when limb salvage surgery is partly borderline, yes, the neoadjuvant RT can be considered, and after that we can go for surgery. One of the problem is that wound healing is an issue, but there are a lot of other biological benefits are there. One, because the volume is clear, the less amount of tissue need to be irradiated, and we have clear-cut plan, we can plan it. But only problem is that post-op morbidity is slightly higher. Chemotherapy, chemoradiation, again the same issue. So if this borderline resectability, you can plan for neoadjuvant chemotherapy and neoadjuvant chemoradiation. Adjuvant therapy, yes, all those tumors, deep-seated tumors, more than 5 centimeters, you have to think of, or close or posterior margin, you have to think of adjuvant radiotherapy. Then adjuvant chemotherapy, again, indication, high-grade tumor, specific histologies, those respond to chemotherapy, like synovial sarcoma, myxoid liposarcoma, extremity than young patients. Old patients more than 60 years, generally the benefit of adjuvant chemotherapy is less. Metastatic disease, again, oligometastatic, sometimes the patient comes with a metastasis in the lung. No, is not a palliative patient. We have to plan for a resection of the metastasis on this one. And simple take-home messages, any tumor more than 5 centimeters or deep-seated tumor, consider as a soft tissue sarcoma unless proved otherwise. Heterogeneous tumor, pathology is very, very important aspect. Metastatic workup is important before we plan that. Core needle biopsy is what you have to use. Only if the core needle biopsy is not yielding well, then you have to plan for an open biopsy. Wide local excision, fascia is an important aspect because the tumor actually he respects the fascia, so the fascia could be a good margin for you. Then clips, that's very important. The clips we have to put it in the margins. Then pathology report is vital, so you have to discuss with the pathologist after surgery. You have to go for grossing. You have to show the pathologist where the tumor was closer. So then the pathologist has to take sections from there and has to put a report on it. Adjuvant treatment is again based on the indications. Thank you. I'm sorry for taking a little bit more time. Thank you very much.
Yeah, topic is open for discussion. Probably a couple of questions can be entertained.
Excellent presentation, sir. I have few doubts. If you see all the guidelines, what we see is 4 large tumors, soft tissue sarcoma, neoadjuvant is advocated every most of the guidelines. How practically you are following that? More than 10 centimeter or
Yes, more than 10 centimeters, yes, we do consider. And neoadjuvant, radiation. Few patients we have, off late, but only recently, because nowadays we don't, except liposarcoma, we don't do it. Liposarcomas are the tumors which present with 20 centimeters, 25 centimeters. Most normally they are well-differential liposarcomas, we don't do that. Large retroperitoneal sarcomas, yes, few cases we are given neoadjuvant treatment because there is a better time to use it. Otherwise, synovial sarcoma, yes, and other histologies and malignant peripheral nerve cell tumors, we don't use radiation, neoadjuvant radiation. Certain tumors which respond well to chemotherapy like synovial sarcoma, yes, we give chemotherapy, or sometimes we are given chemoradiation also, but radiotherapy generally. Actually, there is a, one of the benefit is that amount of radiation what is less. So that is one of the major benefits. Now, some studies show some, additional benefits, but that's always adjuvant and this one is almost same.
I knew very well that you were operating all the large tumors before neoadjuvant. And what's the experience now? What's the morbidity profile? Is it very significant or okay? Especially when there is a need of vascular reconstruction or
Vascular reconstruction is a different altogether. And another thing is that the morbidity, post-operative, post-radiation morbidity, the principle is that first go, if the wound heals, heals. If it develops a problem, finished. So you have to have a proper drainage. The wound care is very important. Once you get a wound morbidity, that wound morbidity stays for a long, long period. Sometimes we have used a flap to cover that and to heal it. Otherwise, generally, the wound morbidity so far for the soft tissue sarcoma is less. But we had 1 or 2 cases very bad, pretty bad, when there was morbidity.
The point is that most of the time the PGs get it wrong that when talk about neoadjuvant therapy,
PGs
they take it as neoadjuvant chemotherapy. But what sir meant was neoadjuvant radiation therapy.
all
in
the
large
guidelines now, it's a common that all the PGs say that more than 10 centimeter, we go for neoadjuvant therapy.
Only for ourselves, the small round cell neoplasms which are sensitive to chemotherapy, we may go for neoadjuvant. Otherwise, it's neoadjuvant radiation, which sir was alluding when he said the large tumors go for neoadjuvant treatment.
The histology is very important. When we plan for example, liposarcoma, no, we don't do that. Liposarcoma, one of the things is that is one tumor. Probably we may avoid, some cases we may avoid a very wide margins because well-differentiated liposarcoma are atypical lipomatous tumors.
If there are no more questions, thank you sir for covering from the entire.
Thank you, sir. May I request the chairperson to kindly hand over a certificate to Dr. Satish Balasubramani, please. Our final speaker in this session. Our final speaker in this session, may I invite Dr. P. Rajan, Professor Emeritus, Astor MIMS, Calicut, please.
Good evening, everybody. Respected Chair and my dear colleagues, let me extend my gratitude to the organizing team of this particular conference, giving me a topic of my choice. Sorry, I'll be disappointing you. It's not oncology. There's two oncologists are sitting there. Anyway, I've got someone to support me. There's Mohandas. That's me, Dr. Rajan. I thought of talking about circumventing luminal obstruction. When I was a pre-degree student, my teacher said that we have coelom. And in very simple terms, that coelom means tube within a tube. And the human body is made up of innumerable tubes. Unfortunately, most of the tubes that we have in our body, right from the aqueduct of Sylvius to the external meatus, it's all solid to begin with, later get canalized. And there you can have obstructions of these lumen, and the effects may be very disastrous. Obstructions in our path are here to challenge you. And obviously you will find one or other methodology to overcome it. You probably might use a big GCB or whatever it is to remove that big stone, but you may probably bypass it, go by the side of it and get onto the road and go on your sojourn. And it reduces the mobility where it occurs as one of the most serious and intractable problems. Now, I'm skirting mostly on general surgical principles because as general surgeons or general physicians, we spend our entire lifetime in treating pain or obstructions and occasionally bleeding, because from the surgeon's hand, these things have gone. As you find that the role of the surgeon who stood tall long time back has been taken over by the endoscopist and the interventional radiologist. So I recall one sentence on pain written by a person called Pain. His name is also Pain, unfortunately. He said that pain makes you think and thought makes you wise, and wisdom makes life endurable. I don't know whether wisdom has made our life endurable. Now, lumen obstructions are blockage of tubular structures, as I told you in the beginning. And when a tubular structure is blocked, its functions are blocked, as simple as that. So going back to the basic pathology, we talk as a third year student, it's intraluminal. Something can occur within the lumen or in the wall or outside the wall. This is basic pathology. The system affected, as I told you, can be from the central nervous system to the terminal portion of the genitourinary system. Anywhere it can get a block, and anywhere it can be disastrous. So the effects of this functional loss can be quite disabling, devastating, and extremely demanding in treatment policies, and at times it can end up in deaths as well. Now the cause can be a structural cause or a functional cause. A structural cause can be anything starting from congenital to a neoplastic process. We have innumerable examples. I'm not going, because of paucity of time, I'm not going into the extent of it, but you have got congenital obstructions, isn't it? You've got congenital hypertrophic pyloric stenosis. You've got functional obstructions. You've got a paralytic ileus called a functional obstruction. So there you have. So it can be structural as a part of cause. If you describe, it can be structural or functional. Now, how do we end up in a diagnosis of a luminal obstruction? Of course, as I was telling the students who are sitting by my side, clinical evaluation forms the basis of anything for that matter, because by clinical evaluation, I mean history taking and physical examination, 90%, over 90% of the diagnosis can be made. But yes, we require imaging, endoscopies, pathological evaluations, and at times microbiological evaluation to arrive at a diagnosis. Why do you want this? We want to locate the site of obstruction. We want to identify the pathology. We want to plan out treatment. And only once we plan out treatment, we can have the informed consent given to the patient as to what I am exactly planning to do. Now, management principle is very simple: relieve the obstruction and restore the function. Very easily said, but it's extremely difficult in certain situations. Now we have got a lot of approaches, medical measures. For example, a spasm relief. You can have a spasm relief if you have got an arterial spasm, either a papaverine locally or at times a sympathetic dissociation. All these things can bring about luminal narrowing, temporarily relieved at least. Thrombolysis is a classical example of a medical measure whereby you can dissolve a thrombus and relieve an obstruction. We've got minimal invasive procedures, which of course involve endovascular or interventional radiological procedures or interventional endoscopies, which include even laparoscopic procedures. Open surgical measures had been the rule of the past. It's not of the present. Now, the methodology. I put some mnemonics to remember. One is remove. As in case of intraluminal obstructions, a stone can be removed. A foreign body can be removed. An embolectomy is a procedure whereby you remove an embolus. These are all removal procedures. Resections, tumors and non-viable structures are resected. Adhesions, etc. are released. You can't do anything about the primary pathology, at least you do a rerouting, what we call a bypass. You can restore lumens today with the help of interventional radiology, stents and dilators and dilatations. Or you can reconstruct without tissue loss. Just few examples only. An endoscopic removal. I asked one of my postgraduate students, it used to be my system, that when they almost finished their posting in my unit, I asked them, give them some topic to make a presentation. For one guy, I gave a topic, how do you treat intraluminal obstructions? Another guy, I gave a topic, the use of intestines in surgery. The second person brought me a prepared topic. The first person disappeared into oblivion. That's what happened. So it's from that day onwards, this has been actually in my mind that somewhere I should put this topic. So endoscopic removal, of course, he did not just disappear. He gave me a picture of an endoscopic retrieval of a common bile duct stone. This you can do with the help of a sonological procedure or without. You can pulverize materials and can bring out. So it is basically a removal, and now most of these removal are by minimally invasive procedures. So you can have image-guided blind or a blind removal. Fogarty, I've put the picture of Fogarty, whose invention of Fogarty catheter has been used not only in blood vessels. A long time back, we were even told that a Fogarty catheter can be used to retrieve common bile duct stones when we were doing open procedures. Resections. Of course, we had been keeping on talking about resections of tumors. Just to mention only a few, somebody was talking about a Hartmann's procedure today morning. So you can resect a tumor and relieve an obstruction. And that's where surgeons stand tall. Adhesions, we generally say that we release the adhesions, and particularly internal hernias are pretty common after bariatric surgery. So innumerable holes that you can make, innumerable windows that you can make, and there could be naturally occurring foci, etc., where you probably may do a release of those obstructing agents which can reduce the obstructions. A rerouting or bypass, what's happening? A rerouting or bypass, as I told you, you can start from the brain for a hydrocephalus to the lower end, where you can probably do bypasses. Arterial bypass is a well-known procedure in case of long segment obstructions. And some of them procedures can be a temporizing procedure and not a permanent. As Dr. Sandosh was talking about a nephrostomy in the morning, it's a temporizing procedure. Even a catheterization is a temporizing procedure. A colostomy could be a temporizing procedure. So also tracheostomy. These are all probably life-saving situations. Now, one person whom I've been talking about is that one of those postgraduates were presenting about the fantastic results of interventional radiology. I was asking him, whom do you thank? He said, I thank God for all the good results. I said, you have to thank this man, Sven Eivor Seldinger. Seldinger was the person who introduced this particular procedure, isn't it? Seldinger technique of entering a blood vessel. And from there, it took upon. We have restored lumens using stents. We have restored lumens by dilatations, whatnot. And we have restored lumens by endoscopic resections. Is it time for me to stop? Okay. Vein lumens, the Mayo Turner, as somebody was talking about, that when you have got an obstruction and when you cannot release the neighboring structures, you probably put a stent, isn't it? The common iliac vein has a stent and thereby release it. Right. Reconstructions. One of the reconstructions which you are talking about structuroplasty, simple procedure whereby structure is relieved by a longitudinal insertion is converted to transverse incision, the lumen is widened. I'm particularly proud to talk about Alexis Carrel, who is a Nobel laureate, whose invention was actually the venous patch. And where we have gone from that particular procedure of a venous patch, the arterial surgery has taken place. Reconstruction without loss of tissue, structuroplasty, and when the YV plasty, a Y is constructed into V, whereby you broaden the lumen. And I was surprised that in phimosis, you can do a YV plasty without doing circumcision. It's something which I got out from the book. So I again reiterate that remove, resect, release, reroute, restore lumens, and reconstruct. These are the basic principles in relieving obstructions. And thank you very much.
Thank you, Rajan sir, for the wonderful talk. You have relived the philosophy of all surgical procedures through your wonderful talk.
When you started, I thought you would talk about intestinal obstruction. That was my myopic view, but you have started from actor Sylvius.
Yeah, everybody thinks obstruction is intestinal
obstruction. You would be
obstruction.
talking intestinal obstructions.
I thought of luminal obstructions, you know.
Sir, it was a very soothing and rhythmic talk. There's a lot of R's, a lot of D's.
That's the way I used to teach students
Yeah,
also.
very good, sir. Topic, discussion.
Sijin is obstructed.
Sir, actually, we were wondering why such a topic. But now we realize that almost all developments in surgery are based on this concept. And it's really hats off to you. Thank you.
Thank you very much. Hope no more questions. Okay.
Dr. Rajan, may I please request you to kindly join the chairpersons? We have a small memento for you, a certificate from the organizers. Thank you, sir. Thank you very much. Thank you to the esteemed chairpersons of the session.
Before we move on to the next session, we will be announcing the winners of the e-poster competition. Please note that the certificates will be given at the valedictory function. The third position goes to Dr. Agni Vyas from GMC Thrissur. The second position is backed by Dr. Geoffrey Joy from GMC Kottayam. And the first position goes to Dr. Kirtana Mohan from GMC Thrissur. Congratulations to all the winners.
We move on to the next session quickly, and may I invite onto the dais the examiners, Dr. K.C. Soman, Dr. Benny John, and Dr. Sulfikar, please. The case presentation will be made by KMCT Calicut, Dr. Vaishak, and Dr. John.
Yes, introduce yourself and start proceeding, please.
Good evening, everybody. We are second year general surgery PGs from KMCT Medical College, Manasheri, Calicut. Myself, Dr. John Parayathotam.
And myself, Vaishak Ramakrishnan. So, the topic of today's presentation is a case of RIF mass. An 85-year-old female patient from Edakara presented with chief complaints of right lower abdominal pain, multiple episodes of vomiting, and fever. The complaints of vomiting was of 2 weeks duration. It was right lower abdominal pain, on and off episodes, and initially started as a vague central abdominal pain, which later shifted to the right lower quadrant. It was preceded by loss of appetite and aggravated by coughing and moving. It was also associated with history of vomiting and fever. The vomiting was non-projectile, non-bilious, and was present for the past 2 weeks and was associated with nausea. And the pain was not relieved by vomiting, and there was no relation to the food intake. There was also associated fever since the past 2 weeks. There was no history of any abdominal distension, no history of blood in stools, no history of any constipation, no history of discharge from the vagina, no history of any night sweats, no history of any lymphedema, no history of any loss of weight or appetite. There was also no history of any swellings in the armpit or the groin. There was no history of hematuria, burning micturition, or pyuria. There was no history of any chest pain, breathlessness, hematitis, or hematemesis. No history of any bone pain or any pathological fractures. The personal history includes she follows a non-veg diet and she had attained her menopause at the age of 45 years. She was a known smoker and was also a non-alcoholic. She has history of type 2 diabetes and hypertension since last 10 years. And there was no history of any COPD, asthma, or TB. No history of any previous surgeries or no history of any similar complaints in the past. She has no history of any familial diseases and there was no history of any cancers running in the family. Going on to the general examination.
Coming to the general physical examination, the patient was an elderly female, moderately built and nourished, conscious, oriented, with an ECOG score of 2 and a Karnofsky score of 60. No pallor, no icterus, no pedal edema, no generalized lymphadenopathy. There was mild pyrexia present. The patient was well hydrated and vitals, pulse rate being 108 beats per minute, BP being 140 by 90 mmHg, respiratory rate of 16 cycles per minute, and a BMI of 23. Coming to the examination of abdomen. After explaining the procedure and taking proper consent, and after adequate exposure from chest to mid-thigh, and in a well-lit room, on inspection, there was no visible swelling or peristalsis or pulsations. The lower abdomen was mildly distended, no scars or engorged veins present. The umbilicus was normal, hernial orifices were normal, and all quadrants moved equally with respiration. On palpation, the abdomen was soft. There was local rise of temperature and tenderness present. There was overlying muscle guarding and rigidity present. There was a 6 by 5 centimeters spherical swelling with smooth surface present in the right iliac fossa with well-defined margins, firm in consistency, with restricted mobility, and the swelling was intra-abdominal and it was non-pulsatile. The extent of swelling being medial border 4 cm from the midline, the upper border 1 cm from the umbilicus, and the lateral border 2 cm below ASIS, and fingers can be insinuated between the swelling and just above the inguinal ligament. Liver and spleen was not palpable, no umbilical node felt, hernial orifices were normal, there was no enlarged left supraclavicular lymph nodes present. On percussion, there was a dull note over the swelling, the rest of the abdomen had a resonant note, flanks were resonant, renal angle was normal, no shifting dullness, liver span was 11 cm with liver dullness noted at the 5th intercostal space. Auscultation, there were normal bowel sounds heard. On digital rectal examination, there was no mass palpable, no evidence of Blummer shelf, no ballooning, sphincter tone was normal, perianal region, no evidence of any fistula, and per vaginal examination, there was no mass palpable or fornices were free. Examination of spine and oral cavity was normal. Other system examinations, CVS, both heart sounds were heard and no murmurs, respiratory system and CNS were normal. Coming to the summary, 85-year-old female patient complains of abdominal pain in the right iliac fossa, which was associated with history of multiple episodes of vomiting and fever, and on examination, a firm, 6 by 5 centimeter tender mass in the RIF with localized guarding rigidity and local rise of temperature with well-defined margins and a palpable lower border. Our probable diagnosis is an appendicular mass.
So we are presenting a unusual case in an 85-year-old female. So what are the symptoms? Abdominal pain and
Abdominal pain, vomiting, and fever.
fever. So 3 symptoms. And with these 3 symptoms, what are the possible diagnosis in your mind, or how will you approach a patient, an 85-year-old lady with abdominal pain, vomiting, and fever?
Sir, the classical triad, the first diagnosis which came to our mind was appendicitis, and with the examination findings,
So
appendic.
do you think the 85-year-old lady is a candidate for appendicitis? Do you think appendicitis is very common
No, sir.
in these age groups?
No, sir. We had differential diagnosis.
No, a differential diagnosis. So probable diagnosis could be, in this case, we usually anticipate tumor-related problems, because 85-year-old is not a candidate for appendicitis. Appendicitis is possible, it can happen, but not a common diagnosis we make. So in this case, why do you think about disease other than GI tract disease?
So rather than GI tract.
So patient has abdominal pain, patient has got fever and vomiting. So could be something related to infective pathology related to the GI tract. Appendix is the last thing we usually think about.
Diverticulitis.
Diverticulitis are common. Any malignancy rupture and producing a problem.
CA, cecum, which can.
Or it need not be related to GI tract, can be related to the reproductive system also.
Sir. Ovarian cyst.
Ovarian cyst can rupture, or ovarian malignancy. Okay, these are the things we usually think about. Appendix we reserve for the last. And when you are going to analyze this, and of course you can exclude a appendicitis by taking a proper history. What is the classical history of an acute appendicitis?
The classical triad of migratory pain abdomen.
Migratory pain. Pain usually starts around the umbilicus,
Migrating to
migrating the right side of the abdomen.
Followed by vomiting.
Vomiting.
Followed by fever.
Yes, fever. So that is such a history available in this patient?
Yes. Yes, sir.
So that is the history you have elicited.
Yes, sir.
So you have thought of appendicitis as the first diagnosis. Do you make a observation like that?
Yes, sir. Because of the classical triad and the examination findings.
No, the provisional diagnosis made is the last thing you make. After completing the examination, you make a diagnosis. So in this case, the history is like that, but we don't straight away think about appendicitis, though even if it is a classical thing. So you have to think about other causes as well, like a pelvic inflammatory disease that can also have appendicitis, pain in the abdomen, then fever, and also vomiting. And fever is vomiting is a non-specific symptom. It can be associated with any pain. And so even if you have a severe headache, you can have pain. If suppose you have got a severe backache, then also you can vomit. So vomiting is not the thing, but when these 3 symptoms put together, you can think about appendicitis. At the same time, you can also think about a pelvic inflammatory disease. Yes, any other positive thing in the history to suggest the appendical abscess?
2 weeks.
So the patient, that's your final diagnosis, I agree. But any extra symptom that can be attributed to a this appendicular abscess?
The duration of symptoms of
Did the patient have any? Yes, he said there is no diarrhea, no bleeding per rectum, no hematuria also, he said. So if it's a case of appendicular abscess, what are the significance of loose stools, hematuria, like that?
Due to
How do you explain loose stools in these patients? There is no, according to you, there is no history like that.
collection can irritate the pelvic collection, which can
Which can have a pelvic collection related to the appendicular abscess. Sometimes the abscess can rupture into the pelvic region and produce a mass per rectum, and also mucus diarrhea which you can have. What about hematuria?
abscess.
Occasionally, the inflammatory appendicular pathology can produce hyperemia of the bladder, and occasionally you may get. These are not common thing, but that can be explained. And suppose this patient is having hematuria, then your diagnosis can be different. Okay, sir.
You have made a diagnosis of acute appendicitis based on the symptoms and appendicular abscess. How long the symptoms had been there?
2 weeks.
2 weeks. Okay. So it is, okay, you can accept appendicular mass as a diagnosis, but still in this age of 85, will you keep something, as a surprise? What are you thinking on that?
Our differential was carcinoma cecum.
Carcinoma
Cecum.
Can carcinoma cecum or any other malignancy there produce appendicitis?
Cecum. Obstructive mass.
Yeah, it can obstruct the appendicular lumen and even produce appendicitis. So you have to keep a high suspicion of malignancy there. Okay, that is the message actually we wanted to convey. So how do you make a diagnosis of appendicitis? What are the tools now we have?
Based on
Clinical
suspicion, Alvarado score.
Mandrel score, and any other thing you will rely on?
Sir,
clinical examination, of course. In your clinical examination, what I found is deficient is on your examination of abdomen. You said the tenderness vaguely. You have not mentioned the quadrants. So abdomen is divided into quadrants, actually 9 different regions, and you have to exactly say where exactly you felt the pain and record like that. If you can get it back, I will show you, and record like that, and where exactly you got the mass you described, upper border, lower border, etc., medial border, but you didn't exactly define where you get the tenderness and all. If you can go to that, I'll come to that. So is there any significance of palpating the inferior border in a right iliac fossa mass?
To differentiate between pelvic masses.
Okay, pelvic mass, is it a mass arising from the pelvis? Then the inferior border may not be palpable. So see, local rise of temperature and tenderness. Where exactly you didn't tell? Overlying muscle rigidity and guarding. Okay, from the subsequent presentation, you may guess that it's in the right iliac fossa, but it's very good to tell that there is a local rise all over the abdomen or in the local area of right iliac fossa, and where exactly you feel rigidity and guarding. When you present, exactly tell in which quadrant. Okay, so if you don't get the lower border, you will think about pelvic mass or something. So then how will you try to feel the lower border? In this case, did you feel the lower border?
Yes, sir, we could.
You could feel. You said you could insinuate your finger. When you don't feel the lower border, how exactly look for that? Yes. You do a per vaginal or per rectal examination and come to a diagnosis in the clinical examination.
Yes, some basic points again. You said pain, vomiting, fever. These are the symptoms. What is that called?
Murphy's triad.
In Murphy's clinical triad, what are the features? Fever. What is the nature of fever?
low grade fever.
Low grade fever, that is a classical in appendicitis. In your case, what was the description or what was the symptom?
Sir, low grade fever.
Low grade fever. Suppose a right ileal fossa mass like this with high grade fever, what will you suspect?
Abscess.
Appendicular abscess.
Correct. There can be abscess formation, or there can be gangrenous change, or something else like other pathologies, other infective diseases. Okay. Here, how appendicular mass is formed?
Appendicular mass is formed basically by the inflamed appendix, the terminal ileum, the omentum surrounding. Basically, if there is
And
any
the part of cecum also that forms the appendicular mass. In this age group, appendicular mass is unlikely. Why it is said so?
Because immunity might have.
Omentum. What happens to omentum in this age group?
because omentum is the policeman of the abdomen. At this
Actually,
stage,
omentum covers these terminal ileum, the inflamed appendix in the center, and the part of cecum. Essentially, that forms the appendicular mass. Omentum will be atrophied usually, or it will be less in amount it will not reach up to that level. That is why this is unlikely diagnosis. Okay. But rarely it can happen, appendicular mass, that you can give as the diagnosis. Then if it is appendicitis, you should think about malignancy, which can cause the base of the lumen and causing appendicitis. So, do you want to modify your diagnosis?
appendicitis may be secondary to.
So you want to give some differential diagnosis also, isn't it? Okay. What are on clinical examination, on palpation wise, what are the features to say that it is appendicular mass?
Sir, a mass in the right iliac fossa, with well-defined borders, intra-abdominal, intraperitoneal mass.
In between, what is my right iliac fossa? What are the boundaries of right iliac fossa?
Sir, the ASIS,
Right iliac fossa, upper, the line goes to intertubercle line, isn't it?
intertubercular line,
Yes. Then
spinal,
the medially the line coming through the midclavicular line. So if there is a tumor or tumor there in that area, how do you classify such tumors?
sir, which is visceral tumors.
Parietal tumors
and the
or
intraperitoneal or retroperitoneal.
Correct. Okay. So you think that this is
Intraperitoneal.
intra-abdominal tumor? Okay. By clinical examination, you can find out it is intraperitoneal or retroperitoneal, isn't it? You said this is a 6 into 5 centimeters spherical swelling with a smooth surface in the right iliac fossa. Why you think that it is appendicular mass instead of carcinoma of the cecum?
Because of the inflammatory features associated and the
Acute onset of symptoms, like 2 weeks duration. Then the history-wise, family history. So we are
Patient present with a 2 weeks history is there.
Yes, sir.
Then?
And then there was associated fever. So an infective pathology might be the cause.
Okay. What are the important differential diagnoses if a patient presents with the right iliac fossa mass, apart from appendicular mass?
mass, ileocecal TB, CA cecum, tubo-ovarian masses.
Okay.
Then
Things in the retroperitoneum?
sir, unascended kidney and undescended testis. And retroperitoneal tumors.
Right side.
Any muscle?
Psoas abscess, lymph node.
These are the differential diagnosis of right hypophyseal mass. So what is the other name of this appendicular mass? What is the other name? Appendicular phlegmon. Appendicular phlegmon. In what way it is different from an appendicular abscess?
Appendicular abscess. Once the appendicular diagnosis of an appendicular mass is confirmed, we monitor the patient. If the
No.
vitals-
Appendicular mass is not confirmed by the monitoring of it. By investigations you can confirm. But no, clinically, how do you differentiate between appendicular mass and that appendicular abscess?
appendicular abscess will have features of local rise of temperature, tenderness, and the patient will be sick looking.
It's a localized abscess. That is appendicular abscess, and that's usually get localized to the anterior abdominal wall and also to the flank. It usually doesn't move towards the peritoneal cavity and do not disturb the peritoneal cavity. There won't be any feature of generalized peritoneal cavity, only local rise of temperature and local tenderness and a well-formed mass. You can almost get a boundary of the mass, whereas in appendicular phlegmon, you don't get a clear-cut boundary. You find that the muscle is somewhat inflamed, the muscle and also the omentum forms a vague boundary, and you get a vague tenderness also. But the mass is well perceived or well identified. But in appendicular abscess, it's well the boundaries are well defined. And what is the major difference between the appendicular phlegmon and appendicular abscess? What pathology had happened in appendicular abscess?
After antibiotic.
The appendix got
inflamed.
a gangrenous appendix. There will be local pus formation. And what you are saying is trying to say is an antibioma. Like
Yes, sir.
if the patient has already started receiving antibiotics, then there could be some element of antibioma formation also. But if in the absence of any antibiotic therapy, the appendicitis which is getting localized will be having a lump like a phlegmon. And do you think this lump, which has occurred after 2 weeks interval, is appendicular phlegmon or appendicular abscess? So appendicular abscess usually observed after 24 hours. And by 2 weeks, it should have either resolved or proceeded with local peritonitis, and one surgeon should have interfered. And here, the mass is there for 2 weeks, and it's not spreading, and it's a well-defined mass, as you said. So what should be a diagnosis? You will go in for an appendicular abscess or phlegmon. See, when there is an appendicular abscess, what about the temperature?
Patient will be febrile.
You get spikes in the. Do you have any other history like that? You said it's a mild fever. There's a local tenderness and a well-defined mass according to you. Say overlying muscle guarding, and there's a spherical swelling. You have clearly presented that it's a clear-cut swelling, but you did not give the actual boundary of the swelling, and you have given the dimensions like 6 into 5 centimeters spherical swelling. But does that presentation go in hand with the appendicular abscess or appendicular phlegmon? And 2 weeks history is also should be taken into consideration. And appendicular phlegmon may not remain like that for 2 weeks at a stretch. Some other consequence would have taken place by this time.
Sir, but the clinical condition, there was no rapid fever spikes, or the condition was not deteriorating, and the patient was monitored, and the size was not enlarging. And
in the absence of these spikes, then we have to think about the cecal pathology rupturing and produce a mild form of inflammation. It need not necessarily come from the appendix alone. Maybe a partial rupture or perforation of the cecum, forming a limited inflammation in that region, then producing a mass which can remain for 2 weeks. Okay, so the problem is the age of the patient. Suppose a young patient, there is no confusion. We can straight away make a diagnosis. Suppose an 18-year-old girl can say it's probably a mass related to appendix. Then you can manage it without much problem. So when an 85-year-old lady presenting with such a swelling, you have to think about other investigations. What are the investigations you would like to do in this case?
CT, diagnostic.
Investigations, just
Diagnostic investigations.
Okay,
We
fine.
proceeded with complete blood count,
blood count. What do you expect in a blood count?
leukocytosis, and shift to
Okay.
leg. Then other inflammatory markers like CRP,
In blood count, anything specifically will, other than this count, anything else? in routine?
anemia.
Anemia you have to definitely look for, because why anemia?
So this age group, and we are thinking about other differential.
Long-standing cecal mass can present, malignancy can present with anemia alone sometimes, only anemia, right? Okay, then ESR is very important. You have to look at the ESR, then
CRT, C-reactive.
Then
CRP.
inflammatory marker.
Fine.
Then sir, radiological investigations like ultra.
Come close to the mic.
Radiological investigations like ultrasound,
CT.
abdomen.
Ultrasound of the abdomen. Okay, that can be the first investigation you do. So any other blood investigation you do considering her age and presentation?
Other LFTs.
Eh?
With the cecal pathology in background to rule out other metastatic
I'll
lesions.
definitely go for a urine routine examination. She's having fever, rightly was a mass. Definitely a urine routine examination is required. Then
LFT,
renal function test and
liver
LFT.
function.
Right. Okay. And electrolytes also. 2 weeks fever and illness. Electrolytes also important. Probably PTINR also. Okay. That much you can do.
Okay, how will you manage a case of appendicular mass?
Or we'll follow the Oshner-Sharin regime, where we'll keep the patient nilperoral and on IV fluids with
Complete bed rest.
Yes.
nilperoral, bed rest, IV fluids, IV antibiotics, and monitoring the size of the swelling and temperature charting.
What are,
Oshner-Sharin regime.
so when will you intervene in between? Is there an indication for that?
Yes, sir. If the there are temperature spikes or the size of the swelling is increasing, we'll intervene.
The swinging pyrexia and rising pulse rate should make you suspect
And appendicular
Abscess.
abscess.
Drainage of the
less
abscess.
than 3 centimeters, then come.
How do you drain the appendicular abscess?
We can drain either by open methods or ultrasound guided.
What do you mean by open method?
Surgical drainage.
So if you are trying an ultrasound, you will go for an aspiration or drainage?
Drainage.
Yes, the drainage, what is the incision you want to make on this patient?
Incision.
What is the incision you will use to drain the appendicular abscess?
Ultrasound guided, we can drain either through RF or through
Sir is asking about
The incision. Open drainage. How do you do the open drainage?
lower midline.
No, that's not. You never make a midline incision. Never approach the appendicular abscess through the peritoneal cavity, because the inflammation is already rounded off, is confined to one area. You should not disturb the general peritoneal cavity. You make an incision right over the lump, and you can separate the muscles. You will find the abscess wall. Just puncture it, drain the abscess, and there you need not spend time for removing the gangrenous bowel, but the gangrenous appendix. Just drain it.
Extraperitoneal drainage of
It's called extraperitoneal drainage,
extraperitoneal.
not intraperitoneal drainage. This is done not to make the
General
localized peritonitis into general peritonitis. We'll wind up because time is already over. Okay, the presentation was okay, but when you put the patient's age as 85, it complicated the whole. Yes.
Better if you had put a second diagnosis of to rule out carcinoma, cecum, then it would have been more appealing to the examiners. Otherwise, appendicular mass, I think, may be acceptable even in this age also, but we need a suspicion of carcinoma. in this case.
Thank you, sir.
Thank you, sir.
May I request the chairpersons to continue? Sir, please, sir. Our next presenter in the session, topic presentation by Dr. Murali, please. Surgical oncologist, GMC Kottayam.
Very good evening. Let's go to the topic directly. Colon cancer, how do we improve outcome? Now, non-metastatic colon cancer, when you simplify it, it's colectomy and then adjuvant therapy. So to improve outcome, we need to improve the surgical outcomes and we need to improve the adjuvant. Now, as we are surgeons, we will initially focus on improving the surgical outcomes. Now, these are the headings I have chosen. Now, what we miss in staging? So it is disheartening to see a major laparotomy has been done and somebody has not palpated the supraclavicular fossa. So postgraduates, per rectal examination, per vaginal examination, supraclavicular fossa, palpation are basic part of abdominal examination. And in imaging, the commonest one that we see missing in colonic mass workup is CT thorax, because we do CT abdomen, it will cover some part of the lungs and the report will be available part of the lungs are normal. That is not adequate. And the basic investigation for a colonic malignancy is CECT, thorax, abdomen and pelvis. And PET is usually taken as a problem solving modality, or if you are going for a metastatectomy. And CEA is mostly all clinicians do CEA, but if the patient presentation is acute like obstruction, bleeding or such kind of a presentation, CEA may be missed. And if you operate and CEA has only a few days of half-life, in 3 weeks time or 4 weeks time it goes to normal. So please do a CEA at the earliest. Now, another thing that is commonly missed if you want to improve the outcome is visualizing the entire colon. See, lesion is commonly at the sigmoid or the rectum, and the report that we get in colonoscopy is the tube cannot pass behind the lesion. So the rest of the colon from inside is not visualized. You are depending upon CT only. So the textbook says in such scenario, you have got a CT colonography can be done, or you can do an intraoperative colonoscopy, but these are hardly ever done. So what we actually do is on table we palpate the colon, and now with the laparoscopic arms we palpate the colon. Okay, and that too, if it is an obstructed lesion and non-prepared bowel, unless it is a very gross lesion, we may miss the lesion. So in such scenario, what is the next plan? In 3 months time after surgery, you do a completion colonoscopy. But this is mostly missed. And the patient comes back after the adjoint, after a year or something, with a recurrence, which would have been prevented if you had done an early scopy. So completion colonoscopy is one thing which can improve the outcome. Then the major thing, tumor board. Please do bring all patients to tumor board. Surgeon is the most important part of it. And you need an oncologist and you need a radiologist and the pathologist. If you are in a small setup where you can't bring all the people together, at least go to the nearby institute or arrange such a scenario where you can at least discuss over the phone with your colleagues. And every tumor board is a small CMEs where you get to learn something or the other thing. Enhanced recovery, ERAS. ERAS does improve outcome, especially ERAS improves infection-related complications and patient outcome, it definitely improves. The patient is out early after surgery, the more chance that he may go for an adjuvant and his outcome improves. Now, pre-admission counseling, most of the clinicians spend hardly 5 minutes with the patient. So you can't counsel everything regarding a surgery in 5 minutes time. You can have a team for counseling, separate team with a trained nurse, a physiotherapist and a dietitian can take time and explain to them every dietary improvements required and everything. Now, I'll just speed up because of the time limitation. Fluid CHO loading that even the medical college anesthetists have agreed to do. So it won't be a problem anywhere else. I'll focus on the routine mobilization care pathway. Please, I would request everyone, if you have a physiotherapy team in your hospital, please ask them to get involved in the patient care and the post-op from the POD 1 itself, so that the mobilization, chest physiotherapy, everything, they can take care of it methodologically and properly. And early removal of catheters, perioperative oral nutrition. So when I started telling the patients about oral nutrition, I said kadala, parippu, muttayada vellam. So all the ammachis came back saying kadalayum parippum bayangara gas adavaru kazhikkilla. And muttayada vella, after 2 weeks of preparation, they come back for surgery and they say, sir, tharavinte muttayarunnu kozhinte muttayarunnu parayathondu adu kazhichittilla. So if I said a few people kadala muttai, paripoda and double omelette morning and evening, that they are gonna strictly follow. What I meant is I don't prescribe this thing, but what I meant is that your suggestions on nutrition has to be something that is relating to the patient's diet. We always suggest the protein powder. Put the protein powder in milk and twice daily and all. So what is written on the cover is 4 scoops twice daily, thrice daily. What actually the patient is using is just like Horlicks and Boost, 1 or 2 teaspoons, or sometimes less than that, like just like chai pudi. So actually that is not improving anything. So a dietitian with a common sense is required to counsel. Now going to the surgery proper, we know the colon was a central structure with a mesentery which happened to lie in the floor in the retroperitoneum overdevelopment, and we have a Toll's fascia in between. So you recreate the original mesocolon by elevating it from the floor, either with or above the Toll's fascia, but make sure that you don't enter into the mesentery compartment. So it is total mesocolic excision. For comparison, I kept 3 specimens. On the left side, this is the actual specimen. On the right side, on the left side, it is a diagrammatic representation of the same. If you see the first specimen, the colon, and then look at the tail, that is a mesentery. The mesentery, look at the above and below, it has got a very smooth outline. Okay, that shows the planes are well maintained and properly dissected specimen. So every nerves, every lymphatics, every the probable malignant recurrent things are there inside that packet, just like your TME in rectum. So look into the next picture. During dissection of the retroperitoneal area, people have gone into the mesorectal plane, and that is not a proper plane, and we have gone into mesocolic plane. Radaro. Now, in the third specimen, it is more worse that in the colonic mobilization itself, we have gone wrong in the plane, and we have gone into the muscularis propria plane. So, just like rectum has got radial margin, the circumferential resection margin, every colon has got a peritoneal surface where the radial margin doesn't apply, but the retroperitoneal surface does have a radial margin, which has to be negative. Now, the classical teaching of colectomy is lift the colon, cut peritoneum in between the vessels and start clamping. So you miss all the peritoneum in between, on the mesentery in between. So the yellow part is that what is missing, and that has to be there with the specimen. Now, this is how a central ligation after TME specimen should look like. The whole mesentery has to be there with the specimen, a right hemicolectomy specimen. It's a very good specimen, so no, definitely not mine. So, standardizing surgery itself will improve the outcome. See, the 5 over local recurrence and 5 survival has changed. See, it is almost or better than what an adjuvant can give in a stage 2 disease. And if I do a colectomy and my number of node count is less than 12, Gangadharan sir is going to give chemo to the patient. Not because stage-wise it is indicated, but because I have done an inferior surgery and less than 12 nodes means my surgery is poor, and that becomes an indication for chemo. Now, moving on to the next heading, indocyanine green ICG. See, every colon has got, every tumor has got a bidirectional lymph flow. It drains up and down. So we have to ligate the vessels draining on either side of the colon. And depending upon how much of the bowel is revascularized, we divide. So how do you actually decide how much it is revascularized? It is by your inspection only, and as you go experience, as you gain experience, it becomes better. So ICG is something which can help you in deciding where to cut. By injecting IV within a few seconds, you get it in the bloodstream, and in the vascularized area, it will be fluorescent, so you can cut. And another thing they suggest is that even if you go into a bit of the ischemic area, the colon may still heal, but it may end up in ischemic strictures. By using this objective method, you can avoid leak as well as strictures. So another fight which has now settled is laparoscopy open in colon. Now, if you're doing a good job, you're good in lab, you can proceed with a laparoscopic colectomy. But I request you, if you're doing a laparoscopy, please audit your results to see that your open and lap results are almost matching and you're doing no harm just for doing laparoscopy. Now, we'll just go to the adjuvant part. Now, adjuvant, my headings suggest MSI, multigene assays, ctDNA. ctDNA is the DNA that is found in the bloodstream. Immunotherapy, neoadjuvant, and reduction of chemo from 6 to 3 months. So I can't cover the whole thing in 4 minutes time, so I'll just explain here and only. From, you know that how much is the adjuvant required for a colonic carcinoma? It is classically 6 months of adjuvant therapy. So in stage 1, you don't need adjuvant. Stage 2, in high-risk patients, you need adjuvant. 3, you need adjuvant. That is it. So people are trying to reduce the amount of adjuvant chemotherapy from 6 months to 3 months. Thereby, the chemotherapy-related side effects like neuropathies are reduced. So that is possible in stage 2. Capox, you can reduce from 6 months to 3 months. Rest investigations are on. People are trying to do that. Now, a change that has come is there is now universal testing of MSI, microsatellite instability. Previously, we used to go for this testing when there was multiple polyps, history of in the family, vagara, vagara. Now, this has become a universal. Every colorectal cancer needs an MSI testing. Just like in breast cancer, every house surgeon knows ERP or HER2 is to be done. Like that, colon cancer, an MSI is to be done. So, hence, we will add a small side on MSI. Microsatellite DNA is a normal thing that is there in everyone. It is just a tandem sequence DNA repetitions. It is there in everybody. It is normal. Now, the commonest mutation that can happen to that area is a mismatch mutation. If a mismatch mutation happens, we have a mechanism to correct it. It is called MMR genes, mismatch repair genes. If they are working well, you call it as PMMR or proficient MMR. If they are working well, the mismatch mutation is corrected and the patient is still back to normal microsatellite DNA. That is, we call it microsatellite stable, MSS stable, which is equivalent to the genetic PMMR. Whereas the mismatch repair gene is deficient, we end up having something called microsatellite instability or MSI-H. So how do we check for this MSI? See, MSI can be checked from the very basic immunohistochemistry itself, which is available in almost all the hospitals with the pathologist. The MMR genes can be tested, whether they are there or not. So, mind you, one important thing for postgraduate is that here, if the genes are present, it is normal. So, positive is actually normal and negative, the absence of proteins is actually abnormal. Okay, negative is abnormal in IHC for MMR genes, so confuse it. Now, otherwise, you can do direct genetic testing of the MMR genes. If you do IHC testing, you will see that almost 15 to 19% may be MSI-H. But if you do genetic testing is not done in the tumor. IHC is done in the tumor. Genetic testing is done in the blood. Okay, because they are germline mutations that will be there in every cell, not only in the tumor cell. So, if you do a germline testing, you can diagnose H and PCC, but that number is only less than 5%. So, the rest of the 15% of patients who has the MSI-H are patients who are having epigenetic mutations or methylation changes or non-specific changes. And the third modality is you can do PCR, where you can check the microsatellite instability itself. After the COVID wave, every hospital now has a PCR machine available. You ask your laboratory to tune it for a MSI PCR, it can be done. It's the same machine that is done for COVID. Just speed up. Now, this news, everyone remembers this news, though the molecule name everyone forgets. So, immunotherapy has been brought up as a new savior. Though Dingen is savior of the common man, this is only for people who have money. But in the future, as Sir said, it is going to come down. just like gefitinib or imatinib, the price is gonna come down. It is going to be, Dingen is going to be ours again. Now, a small line on neoadjuvant. Usually in rectum, everything is given neoadjuvant because it is a local therapy, radiation that is used. Whereas in colon, it is the chemotherapy that is given as adjuvant, not in the neoadjuvant. So neoadjuvant you give when you have bulky nodes, when you think you can't operate upfront or you have got a T4B disease, you can go for neoadjuvant chemotherapy. And multi-gene assays and circulating DNA, you take blood sample and check for the free DNA from the tumor and decide your decisions depending upon that. Is called circulating DNA decisions. And multi-gene assays, they are coming in a big way. Hopefully they will reach us in the near future. Thank you.
We will just invite questions from the audience. 2 or 3 questions only.
Only one question now. Okay. Murali, nice presentation, because I was wondering about this mismatch and repair gene and what is the role in all tumors. But recently only I understood every oncologist insist on those things. I think the newer thing which you just highlighted is very important in the current practice. I think we surgeons will lose your time because more and more molecular techniques for handling tumors are coming. Thank you for your presentation. So just congratulations for that.
Nice presentation, Murali. One query regarding, you have beautifully illustrated the ERAS protocol and you have included not preparing bowel. In this era, we are moving ahead with laparoscopy mainly for colon. How do you incorporate ERAS into that protocol?
I'll change that line to reducing the number of times I prepare a bowel from no bowel preparation. Bowel preparation right now also we do because it is something, it has been debated 1,000 times, Nasa.
It was presented yesterday also.
Yesterday also.
I think people are very clear about it.
The MSI testing, you are telling that PCR can be done. Do they do the MSI from IHC at your center or anywhere in government setting?
No, IHC they do.
IHC
In Kottayam Medical College, they do IHC. And even one PG has a thesis on endometrium IHC. Because endometrium is almost like MSI has got an issue there also. So it's there. They do it. All the 4 proteins they do in IHC. PCR they don't do. They have kept a request for that. They said they'll do it in a year time.
Does it have an equivalent result as we do the gene testing?
PCR. No.
IHC.
No, PCR needs a specimen. PCR can't be.
That is equivalent to a gene testing or by doing a biopsy MSI testing.
No, that is what I said. See, why are we doing a genetic testing is to know whether your sibling is going to get it. That is a major thing. And whether you have got a chance of getting other diseases like endometrium or a close follow required, just like HNPCC. Now, that comes where there is a germline mutations of the gene. For that, you need to check the actual genes in the blood. Whereas MSIH tells you that for some reason, either because of Lynch related or because of epigenetic mutation or because of promoter demethylation or because of BRAF mutation, this gene is not working and there is an MSIH. So it comes, that is MSIH is important when the medical oncologist is giving drugs because 5FU works in a mechanism where if in MSIH the 5FU doesn't work or doesn't work, it is less working actually.
Thank you. Thank you.
Murali, one question. Can you clarify the indications for neoadjuvant chemotherapy in chronic malignancy? Here, some doubts are there.
Sir, basically neoadjuvant chemotherapy goes in after tumor board. Simple logic. Nobody does it without it. So T4B lesions and a bulky node in the base where you think you can't get the proper vascular control because of the large node, you can go for neoadjuvant chemotherapy. The Foxtrot trial that is on neoadjuvant chemotherapy actually is saying they have got better results than adjuvant chemotherapy. But as you know, a colon cancer follow-up is required for 6 years, but they have not reached that time limit to say that it is good. But the way things are going, neoadjuvant is coming in a big way. But right now, as per standards, for a difficult surgery, to ease the surgeon with a difficult surgery, T4B and large nodal disease can go for neoadjuvant.
Okay.
Thank you.
Okay, I think with this note, we'll, please stay on, Murali. With this note, we'll wind up this session. It was a very well presented topic, hand-picked new points, where PGs can actually write for the exam. Thank you, Murali.
Dr. Murali will have a small presentation of a certificate. May I request the chairpersons to kindly do the honors? Congratulations, sir. Thank you very much. Thank you to all the chairpersons of this session. May I invite the next set of chairpersons, Dr. E.V. Gopi, Dr. Muhammad Sajid, and Dr. John Sajid Edwin, please. This is the penultimate session, case presentation on obstructive jaundice by Sri Gokulam Medical College, Trivandrum. Dr. Reshma Mohan and Dr. Remis Raphael. May I invite the chairpersons once again, Dr. E.V. Gopi, Dr. Mohammad Sajid, and Dr. John Sajid Edwin. May I invite Dr. Dayanand Babu, sir, also to co-chair? Sir, please. Okay, thank you, Dr. Dayanand Babu. Dr. Mohammad Ismail to co-chair. This is from Gokulam Medical College, Trivandrum. Over.
Good evening, teachers and delegates. Myself, Reshma Mohan. This is Remis Raphael. We are from Sri Gokulam Medical College, here to present a case on obstructive jaundice. 65-year-old lady hailing from Venyaramud, who is a housewife, belonging to low socioeconomic status, presented with complaints of yellowish discoloration of eyes and high-colored urine since 2 months, loss of appetite and weight since 2 months, and generalized itching since 1 month. History of present illness: patient was apparently normal 2 months back. Then she developed yellowish discoloration of eyes, which was gradually progressive. Simultaneously, she noticed high-colored urine, but no change in color of stool was observed. She gives a history of loss of appetite and weight loss for the last 2 months. She was 72 kgs initially. Now she is 65 kgs, lost 7 kgs in 2 months. And it was also associated with generalized itching since 1 month, more in the evening time, which disturbed her sleep. There is no history of fever, vomiting, hematemesis, melena, no history of altered bowel habits, abdominal pain, abdominal distension, no history of altered sensorium, joint pain or chest pain, no history of seizure, bone pain, hemoptysis, no history of outside food intake, and there is no history of IV drug abuse or blood transfusion. Past history: no previous history of similar complaints, diabetic since 20 years on OHA and insulin, hypertensive since 15 years on medication, no history of pulmonary TB, cardiac, respiratory, thyroid disorders, no previous abdominal surgeries or hospital admissions. Personal history: non-vegetarian diet, disturbed sleep pattern, normal bowel and bladder habits, no known allergies or addiction. Obstetric history: she is married 42 years ago, has 2 children, both were full-term normal vaginal delivery. Family history: has 4 siblings, 2 sisters and 2 brothers. Both her parents died of old age. No history of similar complaints in the family. No history of malignancies. Summary: 65-year-old diabetic and hypertensive female presented with painless progressive jaundice associated with itching, loss of appetite, and significant weight loss.
Come to the examination. Physical examination. Patient examined in daylight after getting verbal consent with adequate exposure and privacy. On general examination, she is conscious, cooperative, well-oriented to time, place, and person. Moderately built and nourished, BMI 23 kg per meter square, Karnofsky performance, status 80, well hydrated. Icterus present, no pallor, cyanosis, clubbing, lymphadenopathy, and pedal edema. Pulse rate 66 beats per minute, regular rhythm, normal volume, no radiofemoral delay. BP 140/90 millimeter mercury, measured in right upper arm in supine position. Respiratory rate 80 cycles per minute, temperature febrile. Head to foot examination. Yellowish discoloration not in sclera, nail bed, posterior parts of hard palate, and under surface of tongue. Scratch marks present over abdomen, chest, and lower limbs. Nail and hair normal. Good oral hygiene. No signs of liver failure. On abdominal examination, on inspection, shape and contour of abdomen normal. Umbilicus inverted and central. All quadrants equally move with respiration. Skin over abdomen, scratch marks present. No visible peristalsis, pulsation, engorgement of veins, sinuses, and scars. No visible swelling noted in inspection. Hernial orifices normal. On palpation, no local rise of temperature, tenderness, abdomen soft, umbilicus, no mass palpable. A globular swelling of size 4 to 4 cm, predominantly in the right hypochondrium. All borders except superior border is well made of. Skin over the swelling is normal with a smooth surface, firming consistency which moves with respiration. Head raising test, swelling reduces in size. Liver is palpable, 2 finger breadth below right costal margin at mid-clavicular line with a smooth surface, sharp round edges and firming consistency. No splenomegaly, renal angle normal, hernial orifices normal. On percussion, liver dullness noted from 5th intercostal space in the midclavicular line till 2 cm below the right costal margin. Liver span 18 cm. Dullness over the swelling is continuous with liver dullness. Rest of the abdomen resonant on percussion. No shifting dullness or fluid thread. On auscultation, bowel sounds heard. Rectal examination, clay-colored fecal staining noted. No melena, no palpable mass. No left supraclavicular node enlargement, no spine tenderness. Other systemic examination, respiratory system, bilateral urinary equal, no added sounds, cardiovascular system, S1, S2 heard and no murmur. Central nervous system, higher mental function normal, no focal neurological deficit. Summary, 65 years old, diabetic, hypertensive female, presented with a painless progressive jaundice associated with itching, loss of appetite and significant weight loss. On examination, she is ectric with the signs of itching, clay-colored stool and hepatomegaly with palpable mass likely to be gallbladder. Provisional diagnosis, obstructive jaundice, most likely malignant pathology, probably due to carcinoma head of pancreas, cholangiocarcinoma, periampullary carcinoma.
So good presentation. The history you did mention about whether it's a painful jaundice or painless jaundice.
Painless jaundice.
You mentioned painless jaundice. Okay. And this is the general examination. This what about skin and subcutaneous tissue?
Skin normal, sir.
Usually look for anything further.
Ecchymosis,
Chemosis.
Peticule. Binary.
Any other epidermolysis like lipoma, sebaceous, neurofibroma? Why should I examine this? Obstructive jaundice, that you are suspecting a malignancy. Any associated skin conditions? Epidermolysis, lipoma, sebaceous, osteomas. You associate with Gardner syndrome or APC gene syndrome. This, as you mentioned, family cancer syndrome. And there is that all organ in the general examination. What else?
No, you said yellowish discoloration and high colored urine. Clay colored stools were there. On your rectal examination, you mentioned, but
History-wise, she
in
is
the
not mentioned.
patient hasn't mentioned that one. Okay. So you showed a picture of a yellow color. What is the description you can give? Yellow color? Anything more adjectives you can add? Yellow color is only yellow color, or any adjective you can add?
greenish tint.
You heard of lemon yellow, orange yellow, like that. Is it anything significant?
Greenish hue.
Lemon yellow color is seen in hemolytic jaundice.
Yeah.
Reddish yellow is seen in hepatocellular jaundice. And
Deep greenish color is seen in obstructive jaundice.
Yeah. So this is what color you observed?
This, greenish tinge was.
Greenish tinge. Okay. Yeah.
Regarding the history, you mentioned about outside food intake. Why did you ask that question?
Hepatitis
Viral hepatitis.
Viral hepatitis. And you also asked about blood transfusion.
A, hepatitis B.
Did you ask about any drug therapy?
Drug, pulmonary.
See,
Isoniazid drug.
yeah, any drugs. See, the idea is that you know that this patient is having jaundice. Now, your idea is to find out what type of jaundice it is. So you have to rule out symptoms to suggest of all types of jaundice: hemolytic, hepatic, obstructive. So all these points must be kept in mind. Accordingly, you will ask questions. Having thought that this is an obstructive jaundice, you must also keep in mind asking questions relevant to find out whether there is a primary malignancy elsewhere. Why is it significant to find out whether there is a primary malignancy elsewhere? I'm not talking about hepatobiliary. Is it necessary for you to know whether there is a primary malignancy elsewhere in the GI tract?
Neuroendocrine.
Not neuroendocrine tumors. So it's very obvious that you have thought about obstructive jaundice in this case. So can this patient have a primary malignancy elsewhere?
Yes.
Yes, obvious, isn't it? So what are those common sites where primary malignancy can be there and where patient presents with a jaundice? Stomach, colon. You understood? So common malignancies which are primary malignancies elsewhere and presenting as jaundice, obstructive jaundice, should also be kept at back of mind. Otherwise, it's very easy for you to get diverse thinking that it's only about hepatobiliary tree. So keep that in back of mind. So your question should include to find out whether there are any symptoms to suggest of a primary malignancy in the upper GI, specifically stomach, colon also. Keep that in back of mind.
So what is the mass you felt in abdomen examination? What is the mass?
It is most probably gallbladder.
What is the reason? Why should you say it's a gallbladder? Point favoring gallbladder.
Consistency was not.
Consistency?
Was different.
What consistency?
It was cystic, soft in consistency. Gallbladder. Cystic
Gallbladder.
in consistency.
Soft. Soft or cystic?
Cystic in consistency.
Lateral to the rectus.
Now, what is the important point? Not the important points for gallbladder. Is it moving the respiration?
Yes, sir.
Moving the respiration. Then?
Not lateral to the rectus abdominis muscle and at the
then?
tip of the ninth costal cartilage.
Gallbladder mass is visible or palpable, which is
More visible on inspection.
in this case,
Was not
Palpation. On palpation, we felt it.
and is a deep palpation or superficial palpation.
Superficial palpation.
So these are point favoring. One is visible than the palpation, and more felt in superficial palpation than deep one, and moving in the. What about percussion?
dull
Continuous.
note. Dull note was heard on the mass. Over the mass.
And it's continuous with the.
Continuous with the liver dullness.
So it is according to this gallbladder. So where is the obstruction? Gallbladder enlarged. Itching is there. Clay color stool. Where is the obstruction? Where is the obstruction?
Lower end of the
Where? Exact place.
CBD.
CBD is non-specific. What is Guruvesh's rule?
Non-tender palpable gallbladder.
In a jaundice
In a
patient,
jaundice patient.
if the gallbladder is palpable, it is seldom due to stones. It is mostly due to malignancy.
Yes, in a case of obstructive, in a case of jaundice, gallbladder. So with this Guruvesh's rule, where is the obstruction? Should be. What is the common spot?
Distal bile duct.
Distal bile means, well, where it should be there? You are suspecting stone or worms or growth. What you are suspecting?
Growth, sir.
Growth. So where is the growth?
Pancreatic malignancies. See a head of pancreas.
Broadly, you should say see head of the pancreas. Why it is not periambulary carcinoma?
No waxing and waning of symptoms was not.
In all cases, you get the waxing and waning of.
And,
Huh?
And
melena is
there
not
was
there.
no melena associated.
Whenever there's tumor destroyed, necrosis tumor, you won't get the waxing typical symptom. Need not be a typical symptom. What about waist, loss of appetite and loss of weight? Severe loss of appetite, severe loss of weight?
There was significant weight loss.
So then
CA
you,
pancreas,
so you, where is the obstruction? CA?
head of pancreas.
Head of pancreas. That you can say, instead of saying lower end of CBD, CA head of pancreas. Okay, so you can say it is a case of obstructive jaundice. Obstruction probably the lower end of CBD, probably CA head of pancreas. Okay. Then we'll discuss the investigation.
One physiology question only. Why this clay-colored stools?
Absence of stercobilinogen.
One, absence of circobilinogen. So which pathway it is obstructed?
Enterohepatic circulation.
Yeah, not the enterohepatic, where the conversion within the gut, it is obscured. So that is why the urobilinogen, biliverdin, and stercobilinogen, that aspect only is affected. Okay. Then the itching, everybody asked that question only. Itching is due to
Deposition of
Deposition
bile
bile
salt.
salts.
bile salt. What do you give for that? Suppose somebody is sitting.
Bile salts deposited in the dermis. It irritates the nerve endings, causes itch.
Pardon? No, what you can give for the patient?
Cholestyramine.
Cholestyramine. What it will do?
Antihistamine.
Compare it with the bile salt. Is it? Yeah.
Suppose the gallbladder is not palpable. Clinically examining, same patient, gallbladder is not palpable. What comes to your mind?
Hilar cholangiocarcinoma.
Means,
Class
Flat
proximal.
skin tone.
so it means that if the gallbladder is palpable, the lesion, first of all, you are thinking about it being a malignancy. Lesion is below the insertion of cystic duct.
Lower end.
If gallbladder is not palpable, one thing you have to keep in mind is, in some scenarios, you may not be able to palpate the gallbladder. That is one possibility. Second possibility is, as you mentioned, it is above the area of cystic duct. In those scenarios, the pathologies are different. So that you must keep in back of mind. All differential diagnosis related to that should be kept in back of mind. You must always examine for features of liver failure. Never forget to mention looking for features of liver failure. What is periambulary carcinoma?
Tumor within 2 centimeters of ambula water.
What are tissues component of periambulary? Tumor around the, you mentioned 2 centimeters. What are the possible
Duodenum.
original tissue origin?
Dude.
Periambulary tissue.
In periambulary, ambulatory part of
Duodenum, second part of the duodenum.
lower end of CBD, then
Part of
Second part of duodenum.
yes, second part of duodenum, third one, pancreas. That is a periambulary carcinoma. It's a gallbladder is palpable, but it is not due to the malignancy. What are the possibilities?
Double.
Double duction, stone in the double CBD and as well as the cystic duct. Then
primary CBD stone.
Mercy
Yes.
syndrome.
Chinese liver flu.
it is very rare in our country. Then
Mucosal-
empyema of
Empyema
gallbladder.
of the gallbladder.
Empyema of the or mucosal gallbladder. These are other conditions you should mention. So how will you proceed this one? Your diagnosis is obstructive jaundice with itching extra is there, or suspecting malignancy, probably periambular or your CA head of the pancreas. How will you proceed?
Investigation for diagnosis first. Biochemical investigations like LFT, coagulation profile, Then radiological imaging like USG,
In the LFT, which are the important investigation LFT?
direct bilirubin, ALP,
Yes.
Serum albumin levels.
serum
ALP and
albumin level,
what other
Doctor-
enzymes? Important enzyme of oxygen jaundice?
SGOT, SGPT.
Alkaline phosphatase.
alkaline.
Alkaline phosphate will be raised. And what is the specific enzymes you will study in the enzyme LFT? Specific enzyme?
5' nucleoside.
5' nucleotidase.
How will you assess the nutrition status of this patient?
Serum albumin levels.
Which is the most sensitive liver function test? Most sensitive liver function test? Serum albumin is the most sensitive because albumin synthesis only by the liver. So serum albumin globulin ratio. So you can assess the nutrition status and for assess the hydration status and the coagulum. These are should be in mind in preparation of patient. So liver function test. Then what do you do? Other investigations.
PPINR, coagulation profile.
Oh, coagulation
PPINR.
profile.
Then USG, imaging, USG,
Image. What image? First, what image?
ultrasound,
USG abdomen.
ultrasonogram.
Ultra. Why you are taking ultrasound?
This is the investigation of choice for
To see intrahepatic biliary radical dilation.
Dilatation intrahepatic biliary radicals. That's the most, and size of the CBD.
CTD, gallstones.
And sometimes you will get the growth also, or ascites are secondary. After your next investigation,
CECT, pancreatic protocol.
what is the purpose of pancreatic protocol? What is contrast CT? What is the purpose?
Vascular operability, to know the operability, resection to know the proceeding of surgery.
Stage
like
of disease,
staging of disease,
resectable or non-resectable?
vascular engagement,
Any extra
uh,
pancreatic
Pancreatic.
disease present or not? With the CT, how will you classify the patients?
Completed.
With the CT, you got a CT. You put in 3 groups usually. What are the groups you put in?
Completely resectable.
Resectable tumor,
borderline
Borderline
resectable,
borderline resectable,
Unresectable.
unresectable,
and
Unresectable.
unresectable. Any other investigation required for this patient?
staging for
Your ultrasound mentioned. Staging purpose,
CT
CT.
chest.
Any
and
other
abdominal
investigation?
illness. Endoscopic ultrasound.
You do OGD for this patient?
Endoscopic ultrasound for FNA, pineal aspiration.
No, no. Instead of endocrine ultra EUS, instead of EUS, it may not be available at the hospital. OGD, then can you roll out the periambulary also?
Can you diagnose the obstructive jaundice by doing urine routine?
Bilirubin is present, urobilinogen absent.
What?
Urobilinogen is absent in urine and bilirubin.
Bile salt and pigment will be present. Urobilinogen will be absent. A simple test where you can diagnose obstructive jaundice. The cause of obstructive jaundice may be different, but at least you can reach up to the level of an obstructive jaundice by doing a simple test. Okay.
Suppose the CT scan, you have done a CT scan. CT scan shows that there is a lesion in the pancreas, head of pancreas, lesion in the head of pancreas. You also mentioned that you will do an upper GI endoscopy. Why do you want to do an upper GI endoscopy in a patient who has pancreatic growth?
Anatomical variant and vascular involvement.
Upper GI endoscopy.
Sometimes the growth will be very small.
Okay, forget it. Now, the reason is because you want to ensure that there is no lesion in the ampoule, right? So that is one of the reasons why. Any other modifications of endoscopy that you are aware of, which you can utilize in these patients?
ERC.
Endo ultrasound. Can do if it is available. Endo ultrasound. Advantage of endo ultrasound. Any specific advantage in a patient with carcinoma head of pancreas? Can do an endo-ultrasound guided FNAC.
Adjuvant
Endo-ultrasound guided FNAC can be done. Right? So, what about the CT scan? Any added advantage of doing a CT scan in addition to finding out the site of lesion? Mets, all those things. You can also do an CT guided FNAC, CT guided aspiration. You can do it. Suppose you are not having a diagnosis in this case, a pathological diagnosis. What is your concept about that? Without a diagnosis, you don't have a diagnosis. Only a CT diagnosis is available, nothing more. You don't have a, there is no setup for doing an endo-ultrasound.
diagnostic laparoscopy.
Diagnostic laparoscopy.
Even without diagnostic laparoscopy is one thing. Even without this, you still can operate. That is one of the important things that you have to understand related to pancreatic malignancies. Even without a pathological diagnosis, you still can operate, provided you have ruled out a metastasis. Okay.
If it is resectable, if worked up, the hydration is corrected, the coagulopathy is corrected. By how will you correct the coagulopathy?
Injection vitamin K,
How much dose?
10 milligram IV.
How many days?
4 to 5, 7 days.
Huh?
5 to 7 days.
3 days is enough. Vitamin K. Then you will decide for operation. What surgery you do?
Whipple surgery.
What are the absolute contraindication of Whipple resection?
More than 180-degree engagement of
Louder,
superior,
please. Close the mic.
more than 180-degree engagement of superior mesenteric artery. Then celiac, infiltration to celiac.
Celiac artery involvement.
Superior mesenteric artery engagement.
Superior mesenteric.
Peritoneal metastasis. Liver metastasis.
Then you can put it as extra pancreatic involvement and SMA involvement. Superior mesenteric artery involvement. And extra pancreatic disease or SMA PV junction involvement. That is the absolute contract. SMA involvement and SMV PV. Superior mesenteric vein and portal vein junction involvement. These are three absolute contraindications of resection. If it is resectable tumor, what surgery?
Whipple surgery.
Whipple. What is the full name of Whipple?
Alan Oldfather Whipple.
Okay, that to extend your knowledge. And after what are structures you are removing in the Whipple? Structures 1, 2, 3 lines.
Head of the pancreas,
Head of the pancreas with the
gallbladder with the
uncinate process. Second,
gallbladder,
gallbladder with the
cystic duct.
gallbladder cystic duct.
Then
Lower end of CBD. The CBD. Then
40 to 50% of gas stomach.
Stomach, distal stomach. Then
2 centimeter distal to the duodenum.
2
centimeter distal to the duodenum.
Louder. Close the mic. Please close the mic.
Correct. 2 centimeter distal to the duodenum.
Not clear. Stomach is clear. Then next.
Duodenum.
Entire duodenum. Then jejunum up to her. Yeah, see structures remain the head of pancreas with uncinate process. CBD up to a cystic duct with the gallbladder. And distal 40% of stomach, entire duodenum, jejunum 10 to 15 centimeters distal to the ligament of teres and the surrounding lymph nodes. These are the structures you removed in a classical Whipple. Any modification of Whipple?
Pylorus preserving.
Pylorus preserving.
Pancreatic or duodenectomy.
Duodenectomy. Which is the first anastomosis we will do in a Whipple?
Pancreatojejunostomy.
Which is the most dangerous anastomosis? Sir, the afraid of which anastomosis? This triple anastomosis.
Pancreatojejunostomy.
Of course, pancreaticogenesis is the typical anastomosis. The chance for leaks, that's always everybody is afraid of that anastomosis. What type of anastomosis? Pancreas?
Ductum.
Any other structure you can anastomose the pancreas other than jejunum?
Gastrostomach.
Any advantage?
Endocrine function can be maintained.
Which endocrine?
Yes, same.
Huh? The result is same whether you are jejunum or stomach. Either you get jejunum or the stomach is possible.
I think time is over. You did well in presentation. Okay, good.
Thank you, Sri Gokulam Medical College. Our last presentation for the day, topic presentation, Principles of Hepatic Resection by Dr. V.K. Pratapan, Gastrosurgeon, Government Medical College, Kozhikode.
Now inviting Dr. Pradhan, he is the HO, head of the department, surgical gastroenterology, Calicut Medical College. And you discuss about the liver resection. So third topic today about the liver.
Good evening, senior teachers, my teacher, Professor, my dear fellow teachers in Medical College inside Calicut and outside Calicut. First of all, I thank Dr. Ismail sir and his team for giving me this opportunity. This is the second time I am presenting a topic in MES hospital. So most of the area is already covered by Gobi sir. I was just sitting when he was presenting his 20 years in liver surgery. So I don't have to say much about liver resection. But few things, I think most of the surgeons might have shown this picture. This is one of the very important picture because this is one person who identified the regenerating capacity of liver. That is, who is that person? None other than the eagle who ate the liver of Prometheus. So what is the current status of liver surgery? The morbidity and mortality of liver surgery was reduced from 70% to 15% and mortality to 2 to 5%. And there is an increasing number of living donor liver transplantation across the world. That is one thing which improved the quality of liver surgery over the last few decades. So there is a progress, improvement in the increasing there is progress in intraoperative bleeding control, better control of septic complications, better knowledge of with regard to prevention and management of post-hepatectomy liver failure. This is an important issue when you consider liver resection. And there are many innovations regarding the imaging, the surgical technique, and there is tremendous improvement in anesthesia and critical care. So, due to the advancement in these technology, there is an increasing number of laparoscopic and robotic liver surgeries during the last 1 decade. So, the basic principle of liver surgery, it should be segment-oriented liver resection. One should maintain a functioning residual liver volume so as to sustain life after liver resection. The common statement, the surgery was successful, but say patient died should not happen when you do a major liver resection. After surgery, the liver should be provided with good inflow, good outflow, and good biliary drainage. So you should have a very good knowledge of liver anatomy. I think that was covered by Gobi sir in the morning session. So the approach to liver is different when you consider hepatectomy for primary tumor, when you do hepatectomy for colorectal liver metastasis. I think Madhu Murali might have covered, I was not there. Hepatectomy for hilar cholangiocarcinoma is still a different type of surgery, and donor hepatectomy for living donor liver transplantation. So the major causes of mortality and morbidity in liver resection: post-hepatectomy liver failure, hemorrhage, post-operative bile leak, and sepsis. So what are the predictors of post-operative liver failure? When the estimated functioning liver residual volume after surgery is less than 40% in a cirrhotic patient, less than 30% in those with post-chemo steatosis, and less than 20% in patients who is having normal liver.
when you have grade 4 fibrosis, when you have high portal pressure, and when there is superimposed alcoholic or other hepatitis, there is a higher risk. And if the age is more than 70, the regenerating capacity decreases. And more than 50% of mortality after liver resection is contributed by post-hepatectomy liver failure. So there is something known as functional resectability. That is, the pre-operatively you assess the functionality of liver. Even if the liver size is big, the liver function may be poor. You can have the volumetric assessment to know whether the liver will remain, the sufficient liver will remain after your resection. You can go for the enzymatic liver function testing. And you have the imaging-based liver function testing like the galactosyl clearance, etc. And you have the computer-assisted visual resection planning on a 3D platform. You can actually do a virtual hepatectomy without the actual resection, and you can see the functioning part of liver remaining after that. So there are many methods to evaluate liver resection. You should have a proper pre-operative staging of all liver tumors, evaluation of proper evaluation of liver function, including the qualitative and quantitative liver function. You should evaluate for portal hypertension, because if you have high portal hypertension, portal pressure, there is increased chance of bleeding and post-op complication, including encephalopathy. And you have to evaluate the remnant liver volume and evaluate the liver anatomy, including the anatomical variations which Dr. Gopi sir mentioned. So these are the FLR recommendations when you consider major hepatectomy. So if you do right hepatectomy, what is remaining is segment 2, 3 and 4. That will represent 31%. If you do extended right hepatectomy, you will have only 19%. That means you will have to do some method to improve the functioning liver residual volume. So there are many methods like portal vein embolization, yttrium 90 radioembolization, combining portal vein embolization with TACE, or you can have the two-stage hepatectomy with portal vein ligation, or what is known as ALPS. I think this is not mentioned in the morning, where you do a first stage where you do ligation of the portal vein and splitting of the liver, and in the second stage you remove the liver by ligating the hepatic artery and the bile duct. There are other procedures like rapid and RAVAS. This is for academic interest only. So this is what is meant by ALPS. You can see the amount of liver regeneration after ALPS. So this is the Rex-Scanley line, which is the major hepatic fissure, which is divides the right and left liver, and the right liver is again divided into segments based upon its vascular supply and venous drainage. So these are the number 1 to 8. Actually, it might have been discussed in the morning. And there are variations like portal vein, bile duct, hepatic artery, etc. These are very important when you consider donor hepatectomy, because you have to preserve the remnant liver as well as the donated liver. So this is another increasing concept that's known as the Glisonian sheath. More and more surgeons are utilizing this concept so as not to dissect the individual structures at the hilum. You will ligate the entire structures, including portal vein, hepatic artery and bile duct as a single structure. So the interesting thing is that most of the variations at the hilum occurs within the Glisonian sheath, and there is less likelihood of damaging these anatomical abnormalities. The second thing is about the hepatic vein. You can have the two major hepatic vein, like the right hepatic vein and the confluence of middle and left. And of course, you have the other type of hepatic veins like accessory hepatic veins. These are very important when you do parenchyma preserving resections or when you do donor hepatectomy. So there is a concept of 3 porta hepatis. The first porta is of course at the hepatic hilum, second porta at the confluence of major hepatic veins, and third porta at the segment of retrohepatic vein with a series of short hepatic veins. So the anatomy of caudate lobe, which is very important when you do surgery on hilar cholangiocarcinoma, these 3 porta hepatis will be involved in the resection. The liver type of liver resection I already mentioned. You can have right, left, extended right, extended left, segmentectomy, sectionectomy, so many different names utilized. So there is something known as the anatomical surgery, and there is a rationale for doing the segment based liver resection, because if you do resect a single segment, you have to ligate that individual structure, and you have an avascular plane between the different segments. And once you do a segment oriented resection, very minimal devitalized liver will remain, and it avoids the risk of bile leak, and you can have we can guarantee adequate resection margin. We can preserve maximum non-tumorous parenchyma, etc. So conventional approach of liver resection, you mobilize the liver, inflow control, ligation of hepatic vein, parenchymal transection and removal of the specimen. Different incisions like the one which we use commonly, the Makuchi or modified Makuchi, the other incisions already mentioned in the morning. So what are the main causes of bleeding? Improper selection, poor preoperative preparation, especially in patients with chronic liver disease. Then poor surgical technique, including poor exposure. Then ignorance of anatomical abnormalities. So how to reduce blood flow during parenchymal transection? You can decrease the CVP to less than 5 centimeters. You can occlude the inflow of liver, either you can occlude completely or you can use partially or you can use intermittent Pringle maneuver, or you can do occlusion of the inflow as well as the outflow. So what is the disadvantage of low CVP? There is a risk of air embolism. There is a reduction in retrograde venous liver perfusion, insufficient left ventricular preload and inadequate end organ perfusion. So you should have a very good communication with your anesthetist before you ask for a low CVP. So this is the paper on Pringle's maneuver. Those are mentioned in the morning about John Hogarth Pringle and his paper published in 1908 Annals of Surgery. So the important thing is that most of the cirrhotic liver will not tolerate the ischemia, and if you do clamping of the hilum, after the release of the clamp, there will be something known as reperfusion injury. That is more dangerous than ischemia to the liver. These are the different types of total vascular exclusion where you either clamp the IVC or clamp the hepatic veins, but there is a very high risk of vascular instability when you do these procedures. So most of the surgeons are not doing this technique except for large tumors which infiltrate the inferior vena cava or very large liver tumors which are difficult to manage otherwise. There are other surgeons who remove the entire liver and do the resection outside and reimplant because of this experience in liver transplantation. So the disadvantages of conventional technique is that when there is a large tumor, when you mobilize the liver, there is chance of tumor rupture, there is chance of dissemination, the remaining segment may become ischemic, and in donor hepatectomy, there is chance of injury to the liver remnant. So to modify this, there is another technique known as the anterior approach where you won't mobilize the liver. This is known as the no-touch technique. You just do a primary hilar control or Pringle maneuver. Then you do the division of the parenchyma, and finally you remove the specimen by mobilizing the liver ligaments. But there is a disadvantage because when you don't mobilize the liver, it's very difficult to control bleeding in the depth. So it can injure the IVC and other major structure. So to modify or to improve the technique, there is another technique known as liver hanging maneuver, where what you do, you make a tunnel in the retrohepatic plane over the IVC, you hang the liver so that you will get a control when you do deeper dissection. So this is the plane which is mentioned in liver hanging maneuver by Belgetti. There are other modifications. This is single hanging maneuver. There is another modification called double hanging maneuver by Cheng. The next concept is regarding the Glisonian pedicle, where if you want to do a right or left hepatectomy, you won't have to dissect the hilar structures. You can just isolate the Glisonian pedicle to that particular segment. Not only for right liver, it can be done for the sectionectomies as well. So the same thing can be applied for laparoscopic liver resection. Now most of the laparoscopic surgeon utilizes Glisonian pedicle approach rather than the routine intrafacial approach. The parenchymal transection, you can use finger fracture technique. Gobisar's very famous technique. You can have other techniques like Cavitron ultrasonic surgical aspirator, water jet, harmonic vascular staplers, ligashore and radio frequency assist devices. So this is a video, it is not mine anyway. So it's a liver resection done by the Glisonian pedicle approach. So the surgeon actually controls the pedicle by clamping the coming across the epidural ligament. Then you will dissect the hilum. Then what he does is he isolates the right pedicle. You can see the right Glisonian pedicle. which is being isolated. The small veins which are branches of the portal vein or the ligament, the attachment that is divided, and then the Clisonian pedicle is isolated. So you can control the entire right lobe by occluding that pedicle. So if you don't require the entire right lobe, you can have the technique of dissecting the posterior sector, anterior sector, etc. by reducing the tape which he used. The same technique is used in laparoscopy as well. You can have the ligation of the veins at that hilum. So this is the hepatic hilum, which is very important for liver surgeon. You can dissect, and if you know the anatomy, there is there are certain gates described in patients with liver for doing the Glisonian pedicle approach, where the Glisonian pedicle is very loosely attached to the liver. So if it is very tightly attached, it is not possible. Here again, the surgeon is isolating the pedicle laparoscopically. So the same thing is possible open as well as laparoscopic and robotic. So the parenchymal transection technique, Gopi sir was mentioning about CUSA. This was CUSA, which is used for doing parenchymal transection. You will get a very clean plane with exposure to smaller vessels. You can isolate and ligate it. Previously, we were using this technique where we have a vascular clamp, which is called the vessel sealing device. The disadvantage of vessel sealing device is that there will be lateral thermal injury, and you will not see any structures differently because you may miss bile duct, etc. and patient can have ischemia, necrosis of that the cut and post-op bile can happen. So the third technique is water jet dissector. So Gopi sir was mentioning about water jet. This was a tumor on, actually this was a cholangiocarcinoma extending to the right lobe bile duct. So we had to do liver resection in a cirrhotic patient. So laparoscopic liver resection, we have three parts with a different level, depth of liver. The anterior part, there is very few vessels. The main vessels are seen in the middle part. So when you do parenchymal transection laparoscopically, be careful in the middle and the posterior part. The donor hepatectomy is done on a normal individual. So you have to be very careful. You should have a strict selection criteria. You should assess for hepatic steatosis. You should do a proper volumetry, assess for vascular and binary anomalies, and planning based upon middle hepatic vein with or without middle hepatic vein. Because this is very important point. If you take the middle hepatic vein of the donor, the patient's residual left lobe may become congested and the regeneration may be delayed. The donor can have problem. So you should plan it properly. Parenchymal transection is done without inflow control, because if you control the parenchyma, the donated liver will be ischemic and it will not work properly. Lastly, this next thing is about the liver resection in colorectal metastasis. It's already mentioned. So there is a shift from anatomical criteria to functional criteria. Previously, when we see patients with bilobar liver met, we have a tendency to brand them as non-resectable or advanced. Now that era is gone. Now there are surgeons doing multiple liver resections for liver metastasis. There is another trend doing a resection with a close margin or even with the R1 margin, giving good results. So the two contradictory objectives when you manage liver metastasis: one, you should do complete resection of tumor, and second, you should preserve as much parenchyma as possible. Most of these patients will receive chemotherapy and they will have some form of chemo-associated issues. So this is one patient who underwent multiple liver resection. You can see something is eaten by an animal or like that. So you can see the pedicle. So these sort of liver resections are commonly done in patients with liver metastasis. And last part is about hilar cholangiocarcinoma. The hilum, liver hilum, is a very complex structure because early involvement of the inflow vessels, including the arteries, and portal vein can happen. So you have to properly stage the disease to exclude involvement. And what was considered non-resectable in previous years has been considered resectable now because of transplant experience. So they do complete removal of the liver, then they do the resection outside and then reimplant, etc. So the so many difficult procedures, exit to in vivo, resections, etc. So these are the important area when you do hilar resection. This is one patient in whom we did hepatectomy. You can see the specimen. The problem of doing hilar resection is that you have to anastomose the bile duct. So the liver resection in hilar cholangiocarcinoma is mainly done to get negative margins. So if you have a possibility of getting negative margin without removing parenchyma, you can go for parenchyma preserving liver resection. So the one such technique is called the Taj Mahal resection. It is done for hilar cholangiocarcinoma where you remove only the area marked under the Taj Mahal. So I think that will be enough for students now. I think I will stop here. Thank you.
Excellent talk by Pradhavan. Now the topic is forward more discussion.
Sir, I have a question. Actually, in atrophic segments, suppose there is a vascular injury or there is a portal vein ligation done, if you reapproach the patient for a resection, there will be significant hilar rotation, anatomical rotation, so that there is total disorientation at the hilum. So how that is tackled, either it is diagnosed preoperatively or what is the intraoperative clue for the management?
I think disorientation you have to manage by getting more orientation by yourself. I think the liver atrophy most of the time is a problem when there is atrophy of right lobe. When the left lobe is atrophy, it is not an issue. Most of the time you can manage by mobilizing the liver. The problem occurs when you have large tumors in that area with rotation or when there is presence of collaterals at that area. Because when you dissect those segments, surgically created or interventional radiology created atrophy will not produce much issue. But if there is a tumor-induced blockage of the portal vein, that can produce collaterals, and the rotation along with collaterals, that will be a big problem. Otherwise, I don't think, I have not faced any big issue. This was the teaching in the earlier times when you have to do the segment 3 bypass for hilar cholangiocarcinoma. If there is rotation, it is difficult to identify the bile duct, because when there is rotation, the bile duct the portal vein will get an anterior plane compared to the what is called the non-hypertrophied liver. I think for resection, it won't be a big issue.
Thank you.
My question is, when you are doing a liver resection on background of hepatitis C or hepatitis B infections, what are the precautions you take? Except for the, the other universal, for the universal precaution. But in that particular setting, do you think you have to modify your surgery or anything like that?
In hepatitis, if there is active hepatitis, surgery is contraindicated during that period, because increased viral load as well as the chances of liver failure in the immediate post-op. In chronic hepatitis B virus infection, there will be cirrhosis. You will have to plan according to the child 2 staging. If child C, B, no resection. If child A, because we don't follow the ICG clearance test as done by the Japanese people. So we have to look at the child status. If child A, without much varices, you have to do an endoscopy, look for varices. If there are varices, there is significant portal hypertension. So you have to expect some form of post-hepatic resection failure. And if there is a tumor which is limited to segment, you have to consider segment-oriented resection or even non-anatomical resection in a cirrhotic background. This is just to preserve the parenchyma. Hepatitis B, sometimes you will see simple hepatitis B positive patient but without cirrhosis or any other features of chronic liver disease. In such situation, except for the universal precaution which you take for the safety of surgeon, there is not much worries. Okay.
I just want to ask regarding, you mentioned about ALPS. Morning also there is a question. So now my question is, how frequently do we do ALPS to have a hypertrophy other lobe in a situation where we have other options like non-invasive invasive methods to non-invasive method, interventional procedures like portal embolization, where you can get. So how popular is ALPS and how commonly is being done?
I think ALPS is not being popular because of the complications of two surgeries and biliary complications which can happen after the first transection. The second issue, you may see a big liver after because the hypertrophy induced by ALPS is much higher than what you expect from the portal vein embolization. The problem is the increasing size of liver is not due to increasing number of hepatocytes. This is increasing hypertrophy of the individual cells which are producing problem. So functionally, the liver may not be that good compared to the one which you get after portal vein embolization. So ALPS is becoming less popular except in situation where you don't have other options.
Still will conclude this session.
Thank you, sir.
Dr. Prathavan, sir, we request you to kindly come in and receive a certificate from the chairpersons. Thank you very much, sir. Move on to the validity session now. May I please invite Dr. MP Srijayan, Chairman ASI Kerala Chapter, Dr. Madhu Murali, Secretary ASI Kerala Chapter, Dr. Muhammad Ismail, Organizing Convener, Rounds 2023, Dr. Jose Kamliar, Organizing Chairperson, Rounds 2023, Dr. Captain Siddiq, Treasurer, Rounds 2023, Dr. Asif Ali Usman, Organizing Secretary of Rounds 2023, and Dr. Muhammad Sajid, Medical Superintendent MES. We'll be giving away the certificates and the prizes to the winners. Request the winners to kindly be ready as and when your names are called out. May I hand over the proceedings now to Dr. Joyce.
Yes, sir. Good evening, my teachers, my colleagues, dear friends. So let us come to an end of 2023 annual PGCMA. I hope this time, as you know, we have included some new things in the PGCMA, that the rounds, the algorithms, and of course, a banquet in rain and firework. So I hope you all enjoy the last 2 days programs. I believe if the judgment is a positive one, definitely the all credits goes to the teamwork headed by the surgery department of MES Medical College, Dr. Sajid, Dr. Siddiq, Asif, Mahesh, and the whole team. And of course, the great support from the officials of the ASI Kerala chapter, our dear chairman, and the vibrant secretary. Only one thing I noticed in this CME is that there is no doubts or questions from the PGs. We purposefully put the programs not very tight, so all the deliberations we had enough time for the discussion, but none of the PGs started, there was no involvement in the discussion from the PG side. I believe we have to find out some
solution for that from the next CME, and definitely we will come out with that for the involvement of the PGs into discussion and their doubts. And I thank all. Yeah, we have in the WhatsApp group we have put that the feedback form. You please fill it up. This is for the coming, how we can improve the next year's CME and the other programs. Please feel free to fill up and send it back. And I thank all, and I wish a safe journey back and all the best. Thank you.
Thank you, sir. Dr. M.P. Srijan, Chairman, ASI Kerala Chapter.
We have come to the last part of the program. It was an excellent academic program. The hospitality very excellent, as Ismail sir told. We enjoyed the evening program with good rain. It was also an excellent thing. Each and every minute aspect is taken care of by the organizers. The name rounds itself is unique. And I would like to mention few other things. The projection of the ward rounds, live ward rounds was very good. And the meet the teachers at lunch also was excellent. And the audio-visual team did a very good job. And a special mention is required for Madam Thangam and Dr. Joycey, who had done the job very well. And we didn't have any confusion in the announcements and comparing part. And I hope we will meet for the Cassicon May program also. And we can understand the effort, energy, manpower, and brain behind organizing such a wonderful program. The organizers' effort is really appreciated. And thank you, Dr. Jose Gamaliel and Dr. Sajid, Asif, Ismail sir, Dr. Siddiq, and the whole team behind the show, the Malappuram Surgical Society, the Department of Surgery of MES Academy, and everybody has contributed, and it has become a grand success. Thank you very much, everyone, and we'll meet for the next February program. And before that, I think Madhu Murali, please come and please.
Thank you, sir. We begin with the prize distribution of the e-poster competition. The third prize goes to Dr. Agni Vyas from GMC Thrissur, whose poster was titled Small Bowel Tumors, a retrospective analysis of 267 cases. Dr. Agni Vyas, I request someone else to collect the certificate on his behalf. Third position. The second prize goes to Dr. Geoffrey Joy from GNC Kottayam. His poster was titled Subcutaneous Rhinosporidiosis Masquerading as Soft Tissue Sarcoma. Dr. Geoffrey Joy, second position, e-poster competition. The first position is bagged by Dr. Kirtana Mohan from GMC Thrissur, whose paper was titled Unraveling the Enigma, a 5-year comprehensive analysis of Hürthle cell tumors. Can we have a round of applause, please? Moving on to the winners of Scientia, the quiz program. The third position is bagged by Dr. Jinsha and Dr. Safwan from Lourdes Hospital, Ernakulam. Dr. Jinsha and Dr. Safwan. The second position goes to Dr. Amit and Dr. Sophia from GMC Kottayam. The first prize of Scientia goes to Dr. Akshay and Dr. Rahul from GMC Alapi. Thank you, sirs. Kindly stand for the national anthem. Dr. Madhumurali would like to speak a few words.
Since my name has been announced, so I don't think words can express what is going through my mind. So I just want to say thank you to all who have been part of this excellent conference because I know that there has been, as Srijan sir said, there has been a huge amount of effort, manpower, and thought process that have gone into the making of this conference. And again, always MES has been good in hospitality. And again, actually, I don't think yesterday's banquet was a setback because we enjoyed the banquet in rain. It was also a novelty. So thank you very much for all the efforts that have been put in, and hope to see you during SICON 2023 in December. Thank you so much.
Thank you, sir, for your kind words.